We are live streaming, everyone. So welcome to our Integrated Care Board. So I'll start off with some of the apologies. So I believe we've got Nigel standing in, ongoing for Jane, who's now retired from Devon, of course. Unfortunately, Nigel sent his apologies. Sanj is out of the country. Carol's had a bereavement, so we send her our best wishes. Nick, Neil and John have sent their apologies, and Jodie. Are there any others, Carolyn, that you've heard of that we need to note? I don't think so. If not, thank you very much. So a couple of other things. I'm going to start with Molly. Welcome again, Molly. Words about Molly and her role here. So colleagues, you'll have been aware that Molly's been engaged by the Integrated Care Board to undertake some work to strengthen aspects of our corporate governance arrangements through some key work and pieces of work over the last few months. As reflected in our agenda today, this work continues at pace and will shape our cycle of business of the board and its committees. And you'll see as the day goes on, hopefully to sign off some radically different terms of reference for our committees. Is recognised that these are is in alignment to the provision of our corporate governance advice and to the committee chairs of the ICB and to the board as a whole. And for that reason, Kate and I have decided that we've determined that Molly will also act as our company secretary for the remainder of her tenure with us as interim governance advisor and with immediate effect on the 9th of November. Welcome formally. Okay, thank you very much. And before I move on to the main part of the agenda, my sort of general welcome, Debbie and Margaret, we have some good news, I see. Would you like to share some award, maybe, that you
Yeah.
Who would like Margaret? Can I invite you, maybe, as the chair?
We have won the Psychiatry of the Year team for digital medicine for our Brain in Hand app. So that's our learning disabilities team. So we are absolutely delighted. We heard about it yesterday. Very timely.
Well, congratulations to you and to the team that did that.
The team is a fabulous, absolutely fabulous team.
Yeah. Well done. Yeah, well done.
Thank you.
A full agenda. Is there any AOB anyone wants to raise? I can capture. No? Okay, so declarations of interest. Anyone want to change or add to the declarations that are in the pack? No, thank you very much. As I understand it, there are no questions from the public. Molly and Carolyn? No? So if I move to the minutes and the actions and the matters, so if I go to the minutes first, as I always do, I'm not going to page turn. If I could ask, are you happy that they are a fair and accurate reflection of our previous board meeting? Yeah, thank you very much. Carolyn and Molly, I've looked down the actions and matters arising. I think most of them can be covered off in today's agenda. Are you happy for that to be picked up as we go through? Yep, lovely. Thank you very much. So I'm going to move on to item 5, which is the health and care vignettes. So as always, colleagues, whether it be papers or the videos, you'll have read them in advance. And I have to say, Lucy, another great selection as we had on here. But is there any immediate observations on any of those that anyone would like to raise? Yeah, Ali.
Thanks, Chair. Yeah, I was really struck by the vignettes this month, and in particular, I wanted to mention the young carers. I had the pleasure of seeing the young carers perform their sketch at the Safeguarding Conference earlier this year. And I think it's absolutely astonishing how they managed to portray such a difficult message, but actually add the humour into it as well. So I just wanted to mention those. And I was also really struck by Susan's story, and
yes,
I thought it was a really good might be the wrong word, but a really good example of some health inequalities and inequities and how we work with people on the islands, particularly through Rachel Wigglesworth's role as the Director of Public Health, to really tackle some of those inequalities and inequities, and obviously through our partnership working as well. So they were the two I wanted to mention. Thank you.
I concur with that. Debbie.
Yeah, so I too was struck by Susan's story, and it's probably just a useful hook to say that we have been invited to resubmit the capital business case for the Isles of Scilly redevelopment. So it's a very tight timeline. Kate and I are proposing to work very closely on this, but this is a real opportunity for us to hear that story, and she's an example of many others, and really look at how can we stretch our digital and technological offers through to the Isles of Scilly. So I'm delighted that actually my colleague Kelvin is also here, because he's going to be supporting us with that thinking going forward, because Susan's example just exemplified the challenges that people face. But also, if we were to be able to improve our digital health and technological offer, it would fit in also with our green and sustainability agendas. So I think there's some real learning for us there. Just while I've got the mic, Chair, I also wanted to commend the penguin soup vignette. I thought it was absolutely fantastic, and it was so helpful to hear what had made a difference to people attending that Pride event. And I think that shows the power of these vignettes, because we are hearing voices that perhaps collectively we would not have previously heard. So a big thank you to Lucy and the team.
Thank you. Rachel.
Thank you. I think, 5 stories that really chime with themes that we're going to hear probably through the board today, and particularly with the Director of Public Health report, the particular groups that suffer poorer health, people from the LGBTQ plus community, carers, people living in different parts of Cornwall. The themes are all there: housing, winter wellbeing. So I think this approach, Lucy, is really helpful in hearing voices, challenging us to be thinking about the things that help people keep well, as well as knowing where the issues are, and looking at those sorts of things that people can do for themselves or through the voluntary sector, like the diabetes and you approach, and the peer support groups, I think, is something in Cornwall we can really learn from, around how people can look after each other and themselves as well.
Okay, thank you. Lucy, can I just ask, did we go back and check the number of young carers estimated in the county?
We couldn't get an accurate figure, so we've just made a generalisation that there are a lot of young carers in Cornwall in the film, and what we will do is I'll follow up with the carers team just to get a lot of the figures I found are not necessarily straight up to date to this year, so I didn't want to put anything incorrect in there.
Yes, if maybe next time you could just come back and tell us how many there are, because getting the right number and also shape and scale on the right number is important. Neil.
Regarding the story of the lady from the Isles of Scilly, I really welcome the fact that in terms of ongoing developments at West Cornwall Hospital, RCHT have links with a public reference group in terms of the development around outpatients and provision in that area. And I think the public's voice, as we've heard it in that vignette, is really important in how we develop services in an ongoing way with people.
Okay. So I think we should also recognise, Lucy, in the annex, the list of vignettes that you've done since we've been here, and I was reflecting also on what impact this is actually having on our board and our board's decisions. So just a couple that I wanted to pick out is everything from the Falls Cars story. I believe you've invested in more since as a result of that. I'll still call it the Brazilian model because I can't remember what we finally called it in Cornwall, but the investments that we've made as a group in that space, there's been a number of these that have genuinely had the voice in the room that have changed what we're doing. So thank you for summarising that, and there are others, but I thought I'd just recognise at least a couple of them that are in there. Carolyn.
Chair, can I just make a note? So we have people who can't see or hear the board at the moment, so aren't showing on the screen. So
another link that's been sent out. So Jess is just trying to put it in.
Okay.
Thank you, Pete.
Yeah, and I'll tell you what that was. That's the part 2 link. So you might want to get a brand new part 2 link sent out as well. Okay. So let's move on, colleagues. Thank you for that item, and well done, Lucy, and to the team for that. So let's move on to Chair's update. I'm just going to ask you to take it as read. Are any questions or challenges on that? Rachel.
It was just the point of the report around the Joint Health and Wellbeing Board, and that we discussed tobacco. You reported around that board. There was a commitment during that meeting around members to sign up to the smoke-free pledge, because we discussed the harm for tobacco. So I just wondered if that was something that you had passed on to come through the decision-making processes of the ICB.
So there's a number of issues, if I'm frank with you, that we need to resolve in terms of the way that comes through the Cornwall Leadership Board and that structure, because things haven't come to here that then have gone to the Cornwall Leadership Board, and we just need to, and I've written to Oscar as well on that to make sure that we have a clear process on that. But on the smoking issue, is there something that you wanted to raise on that?
Rachel's just mouthing it was the Health and Wellbeing Board, but I wouldn't see a reason why the NHS wouldn't sign up to smoke-free pledge. I think most of our organisations, I'm just looking at Steve and Debbie, they're smoke-free sites, although they're not always complied with as smoke-free sites. And the NHS, I think, has been smoke-free for about 15 years. But we would definitely like to reinforce the fact that we think it's a very important thing for public health generally.
Yeah. Can we just have that paper formally come through here, though? Yeah. Thank you. I think it's important because then it's shared publicly here as well, and we can buy into that. Okay. Anything else on the Chair's report? No, thank you. Let's move to the Chief Exec's verbal update. Okay.
So my apologies that it's a verbal update this week, but at the start of the month there didn't really seem to be very much for me to tell you because I'd been off and I hadn't been to many places, and then at the back end of the month there's quite a lot. So I received a petition from Health Watch Cornwall about 2 weeks ago around the opening hours of the UTC at West Cornwall Hospital. Over 2,800 people have signed a petition to say they would like it to go back to 24-hour opening, and I received it with Neil present, with Juliet Ferris and with Matthew Bolter, one of the GPs and a clinical director in the West. I was clear that we commissioned the UTC for 24 hours, and I know RCHT is working very closely to look at how they would get that model up from, I think it's till 2 o'clock in the morning at the moment, so that it covers a 24-hour period. Matthew Bolter actually was part of establishing the UTC 11 years ago, so it was great to have him there to be able to say that we're still very proud of Access in the West and that we'd want to retain it. And I have said, John, that I'll bring the petition to a future board meeting so that we can formally accept it as a board and then do a formal response back to Health Watch Cornwall. I'd just like to, the work that we're doing on the Isles of Scilly I think is really exciting. So we know that when we come to our strategic discussion around workforce later in our agenda, that we probably, I think we have to employ every school leaver that leaves school in the next 10 years in order to be able to keep up with the workforce growth of the NHS. So that's highly unlikely. So what we need to do is to develop new models of care that are built on technology, built on team training, and working on the Isles of Scilly probably is one of our most challenging areas. To get it right would be great. It is going to ask us to look at our professional standards around things like X-ray reading, chemotherapy dispensing, but I think that's great in a county that's often quite rural. And we will have other challenges as our places become more ambitious than we have been around how we keep up with the asks that they're making of us. We've been getting ready for winter, and we'll come back to that later on the agenda when Susan will talk about it. Winter's starting to bite earlier in Cornwall than it has we thought it was going to, and we're starting to see ambulance queues developing at the front of the hospital. We all take that really seriously, and we will be working together to come up with solutions to getting people into the right place as quickly as possible. And we had a national meeting yesterday where some of the systems who are struggling the most with ambulance holds were asked to come into a room with the ambulance services to talk about what we can do to make sure that we get the best possible care for people as quickly as possible and limit risk. So again, we'll be coming back to that over the course of the winter. We also had a letter yesterday around the financial settlement for the rest of this year and going into next year, making it really clear around what financial support we'll get from winter. And that letter is really clear that delivering a safe winter for our people is the most important thing. Delivering our money so that we can break even is the second most important thing. And then making sure that we are keeping up with our elective backlogs is the ask that's being made of us. So as we develop those plans, we'll bring them back through the board. We've had a lot of national excitement around the vibrancy of our third sector. And after colleagues came to visit us a few weeks ago, that excitement hasn't abated. So Susan and I were talking about how we can bring through the board the work that the third sector are doing, supporting people in place, and also some really exciting stuff around the pain cafes that are supporting people to come off fairly nasty narcotic medication through social prescribing and support at place. So there will be a financial benefit from that, but there's a massive health benefit. So for one of our strategic discussions, we thought we should be bringing the role of the third sector and how we build on that going forward next year. And then I think that's it actually. If anybody's got anything they want to pick up.
Any questions for Kate? No? Okay. So Peter, before we move on, have we resolved the link issue? Yeah, I can see that. So the reason I'm asking, I couldn't see him on the first place to introduce him, but we have Stuart Smith on the call coming in, and Stuart, hi there, Stuart. Hi. Stuart is the nominee from the GP Collaborative in Cornwall. He is one of our now formal ongoing attendees. So welcome, Stuart, just in case you wanted to know who he was.
Thank you, great to be here.
Okay, now let's move on to the integrated performance report, item 8, and then we've got the recovering access to primary care paper to deal in this section. Yeah, so we're going to go first of all to Kate Maynard. Where are you, Kate? Over to you.
Thank you. So in the performance section, you will see the track performance against each of the operational objectives in the 23-24 plan. And for the majority of those objectives, the standards that were set within that plan are interim recovery standards, so post-pandemic recovery standards, and these are lower than the NHS constitutional standards. I think it's really important that we understand that. So, for example, 4-hour waits in our interim recovery standard is 76%, whereas the constitutional standard, of course, is 95%. So in many cases, they're considerably lower than the constitutional standard at the moment. And we should also just note that those interim recovery standards align very closely to our SOF4 segmentation threshold targets. At the current time, so we're not only not meeting those constitutional standards, but we've either missed or are missing those interim targets as well, and those SOF4 segmentation standards. And as a system, I think we would all agree that that isn't good enough and we need to turn that around. I just want to highlight 3 key areas. First of all, urgent care, and although there's variation in performance each month, and sometimes it looks a little bit better, sometimes it looks worse, it is not improving, and we're not seeing, in fact, I think Kate's right, winter's come early and it's deteriorating now. It doesn't feel good at all for anybody concerned. Looking forward, and what we're doing about that, and that's very much wrapped around the intermediate care strategy in the winter plan, and we'll hear more about that later in the agenda from Susan, so I won't go into that at the moment. Moving to plan care, and this is an area where we've already missed some of those key interim target dates. So for example, 104 weeks was July 2022 and 78 weeks to 0 was March 2023, and we're still running with considerably high numbers, particularly around the 78 weeks. The key objective, of course, this year is to get us down to 65, nobody waiting over 65 weeks by the end of the year, end of March. And in doing so, we would eliminate the 104s and the 78s. The current provisional target date for this, for achieving that, is September 24, so some 6 months later than we should be doing. So ICB colleagues are working with our provider colleagues to offer choice and mutual aid for quite a considerable number of patients within this cohort of long waiters, and that's through our RMS, the Referral Management Service. I just wanted to flag that using that route actually to offer choice is actually being quite successful in terms of a positive uptake, with people saying actually they would pick up that offer and go elsewhere, which is really positive, because as I say, we do need some high numbers to go and have their operation elsewhere. So the focus at the moment is actually now enabling those operations with those alternative providers and resetting that delivery trajectory date. and we need to pull that right back to March. So there's a big ask ahead there for all of us. And that reset trajectory, we'll have that in next month's IPR. Finally, my third point I just wanted to flag, in mental health, we're currently forecasting delivery of 12,500 of the talking therapy contacts against a target of 16,418. And I just wanted to flag again that this is one of the soft 4 segmentation threshold standards, and we need to be delivering this. We've developed plans and they're continuing to be developed to bridge that gap. We need to secure funding to enable that to happen, and discussions are ongoing outside of here, along with the other discussions about key priorities for this year. And I'm sure Simon will pick up on that when he covers the finance. And finally, we're not achieving the constitutional standards, and we're particularly obvious with urgent care and the ambulances queuing, which isn't acceptable at all. But we're missing these interim recovery standards, and all of this brings that increased risk of harm. And Susan, no doubt, will pick this up in her quality section. So on that note, I'll probably just hand over to Susan.
Yes, please, Susan.
Thank you, Chair. And as Kate says, the focus really, I think, for this board is the harm, both potential and actual, as a result of us hitting a fairly busy time already, fairly early in the year. And this will segue into our winter plan, because our winter plan is focused around preventing harm and keeping people safe. However, we know that we've been tracking through our System Coordination Centre, otherwise known as the SCC, where we meet every morning at 9 o'clock. We've set metrics that allow us to monitor harm, and against that helps us form the actions for the day and for the rest of the week. We're pulling that together, and we will be setting trajectories, as we've agreed, around how we reduce harm and what the injects are to be able to do that. And in that QI methodology that we've all adopted as a system, understanding the actions that we take and the outcomes that they're providing. However, I think both Kates have mentioned the problem that we have at the moment are the ambulances that are queuing. We are starting to see those high numbers of ambulances queuing, and sadly for longer as well. And that's been a feature for us, certainly within Cornwall and the Isles of Scilly, for the last 2.5 weeks, because we've been in System Opal 4. So we know that the quality of care that we are giving is not where we want them to be, particularly for those people that are on the back of ambulances, and also for the ambulance crews themselves. It's not ideal. So we are constantly iterating the actions that we're putting in to reduce that ambulance queue, but also to keep people safe. We continue to make progress against our CQC actions, both within providers of RCHT and CFT, and around our primary care surgeries as well, which we often don't give an awful lot of time to during our quality meetings in board, I mean. So we're working also with our care homes that are being put into special measures by CQC, because we know for the winter being able to support our care homes, and I do have to mention Louisa Forbes' team at this point does a huge amount to work alongside care homes to keep people in those places, because that's their home, so that they don't transfer into hospital. Very important piece of work to support our care homes to keep running throughout the winter. I think I will leave Chris to talk about the mortality and morbidity. We've added morbidity to our system mortality group, which is incredibly important, not only because we're going on to talk about Lucy Letby shortly in part 1. It helps us track harm. It helps us to see some of those red flags before we end up in a position where people are dying. So it's an incredibly important introduction into our system mortality group. I just really want to land the point, Chair, around safety, particularly for UEC, but the impact that then has on planned care as well, because we know that as RCHT have to fill more of their surgical beds to meet the UEC demands, we know that our backlogs within surgery are growing, and that can't be acceptable either, because we're seeing harm on our waiting lists. At our system oversight meeting this week, we agreed that we would look at those areas of backlog within specialties where we're seeing greater backlogs and work through our harm reviews that RCHT have been doing both retrospectively and prospectively, again to work out the actions that we need to take and how we then manage the patient waiting lists appropriately. But it's huge challenge and huge pressure for our providers at the moment. I am happy to leave it there and take any questions, but maybe pass over to Chris briefly to talk about mortality and morbidity.
Let's take Chris and then we'll do questions. Chris.
Yeah, so thanks, Chair. Thanks, Susan. Very briefly, mortality in our morbidity group now meets monthly. There's a regional mortality group that meets quarterly, and it's really to look at the data and not just the standard data such as the shimmy data, but look at, for example, if we spot data, then ask the questions: is there anything to look for in terms of harm, or what can we do to improve quality? And so a couple of examples that we are currently looking at is the data suggests that there was a high percentage of deaths on the elective admissions than expected. Now that's not to say there's any issue there, but it's for us to go away and look and bring that back. So that report's coming back to the next mortality and morbidity group,
Okay.
as is the report around, again, we're looking at deaths on waiting lists for procedures. So again, it's just to look and try and understand, is there any harm being caused by people on waiting list? If the waiting list had been shorter, that harm would have been reduced. So that report will come back to the next mortality group.
Anything you want to add before I open up to questions? Lovely. Any questions for the team? Debbie?
So absolutely appreciate the focus on areas where we can target to do least harm, but as the mental health partner member rather than the chief exec of CFT, I do think that it would be really helpful in planning for next year's business plans that we look at some of the weights that are less visible within mental health services. So we've covered off the NHS talking therapies, but there are subspecialties within it. I could, for example, pick out speech and language therapy, which has seen an extraordinary increase in demand since the pandemic, and that impacts on life chances, education and emotional well-being. So I think if we could book a future slot to look at community weights and mental health weights beyond the statutory targets, I think that would be really helpful.
If you want that in year, is that more of a tactical thing, or is that some strategic dynamic to it?
I'll make the request, and then I think we can take it offline as to where it's best.
Okay, fine. Okay.
Best fits.
So I think it's really important actually, because part of the feedback we got yesterday is that as money flows into winter, there is a suggestion that some services might get left behind. And we also know that the mental health long-term plan finishes at the end of this financial year, which means that the mental health investment standard will no longer be extant. So I think for us as a system, having a mental health board that pulls all of it together so that we're cited on allocations, and that we don't have to do it, but we should be making sure that we're investing in some of our most vulnerable population. So I'll pick that up, and Debbie, if we work together. Thank you.
Martin.
A couple of questions, if I may. On the, I suppose, the system control centre, I think you mentioned, it sounds like data is flowing well to the control centre, but things are still somewhat poor on the ground. You know, the question is really, are we convinced that the SCC has got the tools it needs, the levers it can pull, the things it can put in place, you know, the escalation plans, that when these things turn black or whatever the colour is, you know, something can be turned around rapidly to reduce, for example, ambulances waiting. Second question, I don't think you mentioned cancer, and you know, I'm slightly confused about the cancer graphs. The 62-day standard, for example, seems to show quite a big dip in the last few months. You know, the variance column says that this is an improving nature, so I'm not sure whether the big dip is a bad thing or a good thing, but assuming it's a bad thing, you know, have we assured ourselves we can somehow turn that around and improve cancer performance? Only because I didn't hear it mentioned, I haven't seen a great deal of action.
Let's deal with those two questions. Susan, are you able to answer those?
Yeah, so thank you for raising the SCC. So I think the SCC again is another area where we're learning constantly, because it's been in place now for just over a year. The data has improved massively. I think some of the infrastructure around it, Martin, needs to really start to develop. One of the areas that we're developing at the moment is the coordination of care centre, which is a piece of work that that's being done nationally. We're working with SWAST on that, but it's also how we get our urgent care response better dispatched with the logistics, working with Debbie in the Deloitte's work that she's doing, because all of this is beautifully segmenting into the winter plan. the coordination centre will give the SCC much more visibility on how we're deploying our services, that will eventually lead to, I would hope, more ambulances not turning up at the front door of ED. I think there's more to do around the data, and I know Kelvin is working with the team on the Shrewd model, which I'll hand over to Kelvin to talk about. And we are just, as part of the ICB redesign, we're looking at the SCC and where that is in terms of how many people need to be in it, what skills we need to build on given the learning that we've had in the last 12 months. But I think it's something that we're just going to keep building on, because it's as you rightly say, we've got the information. It's having the right levers to be able to pull to ensure that we're keeping our population
Martin, did that answer
safe.
both your questions to your satisfaction?
Second one's not been answered yet.
No. So the cancer one? Yeah.
And apologies, I should have mentioned there's an elective deep dive which will include all of the cancer standards as well, going through to FPCC at the end of this month, and then that will come back in December through to here. But in terms of those specific graphs, if I'm not sure which one you're looking at, but the faster diagnosis standard, absolutely, that has dropped, and that is a bad thing. And particularly, actually, the performance has been relatively good, not quite hitting the standard, but just underneath the standard. So that needs further investigation to understand what's happening there. And in terms of the 62-day, it's a strange measure, this. We've got quite a high backlog of patients waiting over 62 days. And as you treat them, the measure is counting the percentage of patients who are over 62 days when they're treated. So actually the performance will go down before it goes better as you clear back on the backlog. But again, the detail of that will be in that deep dive, and together with the actions about what we're doing to get back to where we need to be.
So in the order it came, it was Kate and then Steve.
So I just wanted to pick up about the SCC because I don't think we quite answered your question. So we do know that there are issues around escalation and how the SCC is used. So there's a paper later in the agenda around the escalation processes, but around people coming to the meetings with clear asks and offers and knowing their numbers. So we're recalibrating how the SCC works and how we use our own internal escalation mechanisms. That and the access to the data that will come through the procurement that Kelvin's leading for us will give us much better visibility across the system.
Thank you. Steve?
Yeah, three brief things, John, if that's okay. Firstly, on the elective performance, I think the single biggest impact that we've seen is industrial action. We've lost 40 days of activity in this year, so a month and a half, if you like, and Amanda Pritchard nationally has recognised the unavoidable financial impact and the unavoidable elective impact. So that's the context which is kind of we're operating in. And my comment on that, Kate, is the productivity improvements that we see in parts of the system have been really significant. So if you look at RCHT as an example, RCHT year to date is delivering about 105% of elective activity so far this year compared to the base year of 1920, in the context of losing 40 days worth of potential elective activity. So that's really significant, and other parts of the system are working really hard towards that. I would hope that we don't have any further industrial action and there is a resolution that allows us to move forward and progress. The second thing is the information provided in the report, Kate, is really very, very helpful. It doesn't have a significant amount of information about the wider sector. There's a report published today from the Office of National Statistics which talks about challenges of accessing primary care. And that national report is as an example saying that 1 in 10 people can't contact their GP practice on the day, and a further 6% of people who do make contact are told to ring back the following day. Now that's a national position, it's not a local position, but I do think it would be helpful for us to have more performance information about how primary care is operating to complement the information that we have about the CFT, RCHT, UHP and SWAST sector. My final comment is from a wider care sector perspective. I don't think we have any performance information about that. And there's a question, and I've raised this a number of times, about do we intend this report to be a CFT, RCHT, ICB report, or do we intend it to be an integrated NHS health report, or do we intend it to be an integrated health and care report? And I think it does the first thing very, very well, but there's a question about those other two kind of components to the report.
Wait, did you want to respond to that?
Only on the primary care, and absolutely take your point, it's not in the sort of standard IPR. We can look at that and provide more coverage on that. But there is a second item under this section on the agenda which will address that. And I need to go away and think about your point about the wider care sector, because I think that's a good one that actually would.
So just before I bring in Rachel, one thing I would say is that this is a collective accountability here, and as we go through all of today and next meetings, I think we've just got to see this as less about each part of it and completely about we're all in this together. But this is where collective accountability sits. Rachel.
Yeah, I suppose just my reflections would be that I think every ICB is working through what an integrated performance report looks like. So there's a lot of learning from each other. There's a danger you could count everything and not achieve anything, which I think is probably where the discussions are going in a number of areas. So my sense, and I suspect you heard this yesterday in the Chief Exec's meeting, was as a board, you need to decide what are your priorities at the moment and focus on delivering the commitments that you made as a board. And those are the constitutional standards. Those are the standards that the board signed up to in terms of the SOF. They've been very clear. I don't think there's any ambiguity about what needs to be achieved. So my sense is actually from a performance perspective at the moment, your data should support the delivery of those. And then there is a bigger piece of work. And I'm not saying that you shouldn't do that work, but I'm hearing a lot about data, but not so much about the actions that are going to take to address the data. So to the point of the colleagues, cancer is performance is off. What is being done to achieve it and when will it be achieved and by when? And is the board assured that it will happen? Because ultimately, as you say, the board is being held to account. Yeah. So I think that would be my observation of the discussion that we just had.
Yeah, so I think the sense from our board's position, of course, is that we have providers that is inappropriate at one level for us to performance manage. But if you take the language of, as I've tried to use, collective accountability, then we will be asking increasingly as we go through this, whether it be at meetings or particularly as we go through the committee of the ICB, is what are those plans that are in place collectively, particularly in the NHS bit of it. When are they happening? We have got assurance on them? And each of the committee chairs are being asked as part of the revamp to actually delve more into the probing questions of are the plans at a granular level in place and are they happening, and to report back to here for assurance. And to that point, Rachel, in fact, one of the things that I only met yesterday again with Kate Maynard about the fact that in terms of focus, we want to revise a weekly dashboard that will come out to the executives, but also primarily the non-executives of our board, which I would suggest, if it's all right with everyone, that we actually circulate with all non-executives across here, because it's a collective. So we get one set of immediacy of stats that lifts out from what is a very deep report to our top priorities, which is your point, focused on those. And once they start to come out with the trends in it, so it's not just about last week, as I said to you yesterday, it's about the 7-point trending statistically that we'll use to get real trends in here that will allow the committee chairs to ask in the 95 pages, like the cancer question, where is the assurance, what are we doing, when's it happening by, etc. And that can come back here for collective accountability. So if anyone disagrees with that, now would be a really good time to tease that out. Yeah, is it on that point or is it?
Well, it's on a point about the data.
Yeah, no, just okay. Everybody happy with that approach, because this is what the committee chairs will take away. Steve?
Very supportive of that, John. I would suggest we don't limit it to non-executive directors and non-executive members. I think all agencies around this table have a role to play in the challenge that Rachel is just outlined, and I strongly support Rachel's challenge. I think if we can arrive at a dashboard which is absolutely clear on the performance against avoiding a conveyance to an emergency department in the first place, and ensuring the emergency department doesn't admit where that's not necessary, on ensuring that UHP or RCHT have the maximum possible flow through their organisation, and ensuring there's a flow out of the organisation. I think a dashboard like that, which is available to every part of this system, would be really, really
If everyone's
helpful.
up for that, I think that's a fantastic suggestion. And in fact, the one thing I just want to say again, in terms of messaging here, is, again, I'll use this phrase I've used before, no one need be defensive in this, and we don't need to start from justifying in some ways why we're in this position we're in. We ought to spend more of our time asking what are the plans at granular level that we are going to put in place that are actually going to change this from an assurance perspective.
But it has to be more than UEC. So Steve's described the UEC pathway, really. So one of my comments around and it was made yesterday at the national meeting, that productivity levels are high across the whole of the NHS, but we're not eroding our backlogs. So we're busy doing work, but it's not reducing the backlogs around 65 weeks, and it's not impacting on cancer. So almost we're not maybe answering the right questions. So we just need to come back round to make sure that we are, and that we've got that as an outcome, not just as an interesting bit of information.
Ali?
Yeah, thanks, Chair. So care and wellbeing reporting through quarterly integrated performance reports in the council. But I'm really happy to have a conversation outside of this meeting about how do we unpick some of our dashboard to come and share with colleagues around this table. I think we've shared our outcome delivery plan where we've got our interventions and our metrics with colleagues previously, but really happy to revisit that and share the the progress that we're making against those metrics as well. Thanks.
I was just going to add to the productivity point. So, and just to be really clear that we, in terms of the formal way in which productivity is calculated for our system, we are, based on the month 4 data across the Southwest, our productivity is still almost 20% down on 1920. So irrespective of how you pull the numbers out, when you take spend in relation to activity, we still have to do a lot of work to bring that back up to a much better position. And again, that points very clearly in the direction of how we're spending money on workforce and agency. And we do need to tackle that very quickly.
So what I may suggest, if I may, is that we note all of this, and we're going to have a more a discussion in part 1 under the winter plan that maybe some of these things can tease out on. Steve, one of your points I want to just come back to in terms of the recommendations here, because I think it's an excellent point as well. We've made a number of excellent points, but this one I wanted to tease out. The recommendation talks about considering a wider ICS approach. And I have seen this in quite a few of our IPR conversations. I think we need to cross that bridge pretty soon, taking Ali's point as a suggestion. If we can get the NHS bit done, cleared first, while in tandem with it, we're working on the next one that actually starts to do it in the round, else we'll try and do everything and it'll be March. Whereas I'd rather have that first bit for the NHS bit done, and then while we're working with it with other colleagues, not just the council, by the way, but whatever partners there are to do that. Does that work for you, Steve?
Yeah, very supportive of that.
Ali?
I was just going to say Q2 was discussed at Cabinet yesterday.
Okay.
So I'm really happy next month to bring Cabinet to
Very good.
kind of quarter report. I need to work out how I unpick it, but happy to share it all as well.
Yeah, no,
it's in the public domain.
Thank you.
Thanks.
Okay. So can I move on to the recommendations? Yeah. Okay. So we've discussed that. There are lots of key issues, and like I say, I suggest that some of this will come into focus in the winter plan agenda item in a second. Are we assured the exception reports under the performing area provide satisfactory assurance? Can I say no? They're not providing satisfactory assurance at the moment? Or am I an outlier in that?
No, I think you're right. So we can't say that we're assured that what we're currently doing is going to meet the backlogs, the cancer access standards, or the delivery for winter. So I think we should be bringing back to the next board the actions that we're taking that will allow us to be able to do that. Because the other message loud and clear yesterday was we've got the workforce to do the backlog recovery. We need to do it.
Everyone happy with that? I just couldn't propose that recommendation based on what I just heard. So we haven't got assurance, and we're asking for that to come back in December, I take it then, are we?
Yep, we can take it through committees.
Take it through the committee. This is, when we get take it through the committees, and then we'll do that. And I think we can actually note, and we just talked about the fact that we'll get the NHS dashboard up and running with Kate and colleagues to ensure that it's something we collectively are happy with, but it must at the very latest be up and shared before our next board meeting. It really is. It really has to be. Is that right, Kate? Thank you. Everybody happy with that section? Okay, so as part of section 8 on the agenda, there is still the recovery access to primary care. So Chris, can I invite you to introduce that?
Thank
People
you.
will have read the document.
Yeah,
so.
that's right. I'll be very brief. I'll take the paper as read, and it's to provide update and assurance on the progress as requested in a report from May that was published called the Delivery Plan for Recovering Access to General Practice, which really wanted us to set out what we were doing around what's called the 8 a.m. rush, when there's a, as it were, stampede for patients to try and get an appointment with their GP, and then improve that access, but also improve that they get a clear explanation of what's going to happen to their request on the day, and not be told to come back another time. So just a couple of points to highlight. Obviously, general practice is part of a system that we've talked about in terms of UEC, for example, is really important because it has the most touch points in the system. So general practice, has the most touch points with our population on a daily basis, and you can see in terms of the data, in terms of performance, there's a huge variation when it comes to how quickly people can get appointments from excellent to where clearly we need to improve quite significantly. And I'll take that point, Steve, that you mentioned around improving data around this, because I think that's something I'll talk to my colleagues with the LMC and the GP Collaborative who are also listening in. But the key point really is around ensuring that we are addressing 4 key points: empowering patients, using the NHS app more better self-referral pathways, implementing modern general practice, which is really about digitalization, cloud-based telephone. There's only 3 GP practices that don't have that. We're addressing that. Building the capacity, so a stronger, resilient workforce, and cutting the bureaucracy, which is what we've been doing, again, with LMC colleagues and the collaborative. And as you can see, we are some of the areas that have been delivered, and some are still in work in progress, and the ask is to bring a further report back in the early next year.
All right, thank you. So I'm going to invite some people to speak first, and then others who want to comment. So, Stuart, welcome. I introduced you earlier on. As you're leading as the attendee for the GP Collaborative, what are your thoughts, please?
Yeah, thanks very much for that. I mean, Steve mentioned some national data, and I think we all agree that the 8 a.m. rush is something that we want to avoid. I have to say, I would, ordinarily Cornish GP outperforms national data, and certainly across my sort of central patch, for which I'm the lead CD, I'm not aware of any practices who turn people away and ask them to call back tomorrow. So I think there is progress being made from that. I think just really important to remember the constraints that general practice is operating under in terms of workforce, workload, and estates pressures. And there are some impressive transformative work going on in other parts of the country. There's models in Sheffield and Manchester and Dorset, much more kind of place-based models, but that has come with significant investment in our general practice. So I think whilst GPs all aspire to meeting demand, the frank realities of it are that the workforce and the workload makes that very, very tricky. That's not to say that we're not making progress, and there is a consensus across the LMC and the Collaborative Board of GPs of a model of transformation in primary care along the lines of what's sort of been going on in Sheffield, which would make workload and work pressures much more sustainable, and hopefully help us concentrate on what we all know is the best evidence-based medicine, which is proactive, preventative care. But as I say, that the models where it has become more successful have included significant investment in in-hours primary care. So, I think there's cause for hope. I would say that Cornish GPs are working extremely hard. There's lots of very impressive, innovative work going on, but there's also extreme fragility within our general practices. And I would say almost every PCN in the county will have a practice that is facing genuine sustainability issues. So, I think just on the data point, I totally appreciate the need for more data in primary care, and very keen, obviously, to work with our LMC colleagues. And,
thank you very much.
With Chris, yeah.
Okay, thank you. Nick, you were going to be on my list, so you put your hand up. Please go next.
Yeah, not like me to volunteer for anything. So just coming back to Chris has started working really with the tackling bureaucracy side of things, and I think that's massively important, because if general practice can concentrate on doing general practice, we can do masses to help a corner of the population, but we need to be able to sort of concentrate on general practice and not doing other things which are sort of just counting beans or doing other people's work. So I think that's massively important. And as Steve said earlier on, that getting the information is massively important as well. And obviously there was a deep dive planned into primary care and general practice by the ICB, which has been shelved for the time being, I believe. And I think that a lot of people put a huge amount of work in preparing the evidence of where general practice is at the moment, and so the sooner that sort of stood back up, I think, and we get that information shared, the better. And I just want to echo what Stuart was saying, is I think currently at the moment about 40% of the Cornish population are looked after by GP practices who are on the at-risk register for the ICS. And those, the reason they're on the at-risk register is they're working to the extent of their capabilities and beyond, often with significant issues with staffing. So Cornish general practice is functioning above national averages, as you say, but it's on a knife edge at the moment.
Okay, thank you very much. I'm going to invite 3 other people. I know we're slightly over time, but I think it's important we also note the fact that we've actually got a number of GPs who are on our board in one way or another. So, Andy, what's your perspective on the paper?
Thank you, Chair. I'm really glad to see this paper and really glad that it's come through PCCC. It clearly is a work in progress.
As a committee, you mean?
Yeah. Yes.
Thank you.
Really, I see it as a work in progress. So I think board would value being cited on the development of this work, because there are a number of the work streams that are showing as amber and red and off track. And I think given the picture that my colleagues on the screen have painted of general practice working hard and struggling in areas, it would really value some focus from the ICB.
Thank you. Neil, you know I'm going to come to you. As a former GP and the chair of our quality committee, can you give your perspective, please?
Well, I think one of the problems with papers is that they don't actually always give you the full picture of the work that goes on. And I think when we come to the winter plan, you'll hear of the collective work going on by GP teams and local neighbourhood teams to try and underpin some of the problems we started out talking about today. I know that as early as April, May, the ICA in the West were actively meeting to address how general practice and community neighbourhood teams could address the problems that we face in winter, particularly around frailty. And this new model of care that Stuart talks about is preventive and proactive around issues that include frailty. I think we need to talk about people's needs and personalised care. That's what people really want from close to home care. But it's really important to note that there is a lot of work going on, despite all the pressures, on the ground to underpin the problems we all face.
Okay, thank you. Final question I'd like to pose is to Kelvin on the digital front, particularly as we're entering winter, because it'll come up potentially under the winter section of the agenda. How are we supporting general practice from a digital perspective?
So in terms of digital, as Chris has already highlighted, helping GP practices to move on to digital platforms, so they've got modern telephony to handle that traffic. We're absolutely working with colleagues in terms of the self-referrals process, which I think is referred to in terms of MSK, and widening out those referrals processes. So the platforms are in place. It's working through getting some of those actually up and running in time for winter.
Thank you very much. Yes, Rachel.
Thank you. One of the things I noted from the performance report around primary care was around the higher rates of appointments, but then potentially the higher use of non-GP appointments, which I think shows a little bit of a direction of travel for Cornwall, that we are using the ARS, the other roles that work in primary care, to sort of divert. And that's the intention of them, isn't it? To support and prevent. And I think that GPs, the job that they're doing in general practice, if we can use those alternative roles, particularly to do the preventative work, there's a lot of options of support to help people keep their health well, which we're not able to connect to because it's it's that capacity and time. The self-referral routes that are mentioned in the report, I welcome those, but we know that we're only referring, for example, 15% of eligible people for digital weight loss, which is an effective intervention. You know, there's all these connecting things that can keep people well, which are where we should be focusing that support to prevent the diabetes, the issues that lead to the complications and need for treatment. So a sort of well done for that side, but a more to be done on that, linking the preventative using other resources.
Yeah, I suppose what also there is good practice in Commonwealth, and generally in the Southwest. To your point, we've significantly expanded the wider roles around primary care, and that isn't necessarily easy to read in the figures, which are just about access to a GP. So I think to Neil's point, it's about the wider how you build integrated care teams, how that links to your neighbourhoods, and there's something about the primary care practice of the future, and maybe that's a strategic discussion for the board in terms of the art of the possible, because there's some really exciting work going on around what that might look like, and I think there's pockets of that doesn't necessarily come to a report of going on actually in your system. So maybe an opportunity to shine a light on the things that are going really well around general practice that could be spread across as part of that vision.
So Chris, in order to wrap up, I've just got one question to ask you, and then you can wrap up the paper. In terms of the broader strategic linkages with intermediate care strategy, social prescribing, and our Brazilian model, how are these all being linked together to actually support recovering access to general practice? Because there's no silver bullet to this. There are all lots of component elements. And are we capturing them all?
I think we will capture them better and we'll talk about our clinical strategy and how our new operating model, how we will use that to have programs of care, which is really going to push that channel shift into more care happening in the community, but supporting the GPs with that channel shift of not its workforce channel shift with that personalisation, place and prevention. So that's very much at the forefront of our clinical strategy.
Thank you, Kate.
Thank you. So one of the things I just think we need to be really clear about is that we've got excellent general practice in Cornwall and the Isles of Scilly. And when we look across the country, I think it was us and Devon where our patients had their highest level of satisfaction with their access to general practice. And at the meeting I was at yesterday, we were reminded by Amanda Pritchard, who's the Chief Executive of the NHS, that despite all the national headlines around general practice, most people feel they get a very good service from their GP. So that's my first point. General practice is under pressure, and that's because we've grown a way of seeking help where the GP is the only universal offer we've got really for our people, is where people go to. And Rachel's right, we've developed the additional roles that come around general practice. In the Southwest, I think, is the only region in the country that has spent all of our money, and we could spend more if they'd send it to us, because we have teams ready to take additional roles on board. The whole point of our intermediate care strategy is we have expert people doing expert things in the places that they are. And I think if we had a place-based deep dive into how we've got teams of people coming together with and around general practice, then that is the surety that we're starting to see new models develop. And as we go forward into next year, and when we're talking really about how we use left shift, don't we, but how we move from institutions and intervention to person, place and prevention, then the movement of resource in the form of staff from institutions to place, I think plays to your ask, Stuart, around additional resources into primary care. Their long-term condition management, prevention can be the discussions that we're having to keep our population healthy and well. So I think it's a space we'll keep coming back to. I think we need to get the metrics right about primary care, because to go back to Steve's point, we've got a really good story to tell. I just wanted to pick up Nick's comment around 40% of general practice in Cornwall being under pressure, and going back to Kirsty Lewis's team and the fact that we do have a lot of support for practices under pressure. And then that team works really well through our place directors. So again, in terms of mapping out what we can do where to reflect that the whole of Cornwall is managing an awful lot of change and morbidity, and we're just using all the resources we've got to do that. And that's Chris's point around teams of teams. The ICB board doesn't do this work. The integrated care areas do this work, owned by their general practices. And it's really important for us to remember that. I think Emma's hands up.
Sorry, I couldn't see you.
We'll be happy to support that deep dive, Chris, because there's an awful lot of that work that's being done within the third sector at place around primary care. So that it would be really great to see that much more visible collectively at place. But I just wanted to pick up on Rachel's point, because I think we collectively need to challenge up the line. These aren't the right things to be measuring primary care on, and I know we know that, but actually I think a formal suggestion that we need to be measuring a much broader cross-section of what primary care do, and perhaps if we could give Rachel a bit of weight to that feedback, it might be helpful.
Yes. Yeah. Okay, thank you. So Chris, are you okay if we move to recommendations? Oh, no. Fine. So the recommendation, colleagues, is that we note the contents of the paper. And we've had a pretty good conversation, particularly now we've got a significant number of GPs contributing to the debate as well. Okay? Yes, let's take that. Thank you very much indeed. So before I move off item 8, if I could turn to you, is there anything that you feel we've not covered off under the integrated performance report that we should have done?
The only thing that we haven't picked up is that we've had 2 NEVA events, and I don't know whether they're both in the same institution, but we've had 2 NEVA events, and it's the learning from it. It's not the fact that they've happened, and also that when we have services under pressure, that's when we start seeing things like this happening. So I think for 2 reasons we should be really interested.
Okay. All right, noted. Thank you very much. So let's move on to item 9. So again, thank you colleagues for taking the time to write your committee and partner member updates. I'm going to take them all as read, and I'm just going to reach out to, by exception. Does anyone like to raise any points on there? I'm going to go to the committee chairs first. Anything anyone wants to raise from your reports? Looking around? No? Thank you very much.
Sorry, John.
Yes,
wasn't
Neil?
quick enough. I think it's really important, having heard what we've heard today, that I actually have an opportunity to not assume anything about the 4 points that I made in my report around the integrated care area report. And very briefly, they are: the board and its partners are asked to work collectively to prioritise out of hospital care as much as hospital care, shift resource closer to people in the community earlier in their pathway. We think, in terms of health inequalities, that maybe we are spending money on people affected by health inequality, but we're spending it at the wrong end of the pathway. And looking at that NHS Confed report, there's now evidence of that. We need to shift resource, and we need to integrate and co-locate staff. And we need, and this is relevant to what we've just talked about, to provide commissioning and contracting support required for new place-based models of care. And I'm going to go one step further, John. This is really important. The ICA committee timing is not brilliant for this board, but it was held on Tuesday. And there is definitely an avowed wish for an ICB preventative strategy as well as a clinical strategy. It's really important. That came out of the meeting. And there are some fantastic examples that have been raised. And I note on the board forward plan in January, a strategic meeting, that we are looking at green and sustainable agendas. I'll give you one brief example of why that's important. We heard about something that's happening in Cornwall, which is GPs prescribing fruit and veg boxes to pre-diabetic and diabetic patients. And at that meeting, evidence, clear evidence, was provided that demonstrated actual impact on the pre-diabetic and diabetic nature in terms of blood tests on these people who are getting out, and it's more than just eating fruit and veg and not processed food. It's about a holistic approach to how people. And the challenge given, and I think you need to hear this at board, is that if we had 5% of the budget spent on diabetes in terms of clinical and prescribing budget in Cornwall, 6,000 patients could be helped in Cornwall pretty immediately, pretty quickly, to address something that will have a huge impact on what we look at over the next 5 to 10 years in terms of health. And I recommend that to you, and we're learning that through the sessions we hold at ICA where people can share best practice going forwards. There are national examples of this. There's one in Lambeth, and it's about going out and reaching out to people, not waiting for them to come to you, and working with people who need to look at different ways of health and well-being. And I'm sorry, John, to take up time, but it was so important. I think it needs to be raised here.
Well, thank you for that. And can we make sure that element that you wanted on the forward plan is picked up? Because you mentioned it to me beforehand. Could we pick it up for January, please, which is the next strategic one? Yeah.
So I think as well, Neil, we're looking at clinical priorities for next year. Diabetes, cardiology and respiratory are looking highly likely to be clinical priorities. And what we'd like to do in terms of the programme spend for those conditions is to move more towards prevention than to ultimate tertiary intervention. So it gives us the opportunity to move the money around in the pathway. So I think it's a good provocation, well made, and we need to keep coming back to, have we done that? Because you're right, it's the way we'll make the greatest impact.
We still need to think about people as people, not conditions.
Yep.
Okay, thank you. Anything from the ICB participants that they want to pull out from their reports? Emma?
Two points. I'll pick up the second first because it links to Neil's. There is a huge role for the third sector to play in prevention generally, not just condition specific, but across the whole life course. So I would really welcome the board's support to work with my sector colleagues to develop proposals around prevention long term. And that's something that we've spoken to Rachel and other colleagues. We'd like to do a really collaborative piece of work to look at the art of the possible for our long term future for Cornwall. So that's something I'd really welcome the board's support on. The other thing is a slightly more targeted one around the real living wage, and whether or not board will consider, and it might be something we want to pick up in a future board meeting, but coming back around support for Cornwall as the first real living wage county. It's something that we've taken working with Public Health and the Council, the poverty event a couple of weeks ago. So we'd like.
So I'm going to ask Kate, Patrick, and Tarn to respond.
So the first bit is that I think what the first point was you've described ICP working. So I think you're exactly right. We should be taking a piece of work through this board into the ICP that from a long-term prevention strategy, what's the role of the public sector in Cornwall? The NHS has got a lot to do, but so is education, so is housing, so is every touch point that we have. So it would be great if we could agree what our long-term prevention strategy as an ICP is, and then that plays back through the Health and Wellbeing Board and our promises to our people in Cornwall. My second point was I didn't know that I forgot what was the meeting that you had, the
National Challenge Poverty.
The National Challenge Poverty, and how that feeds into the way that we set our budgets. So John was at a meeting of the Cornwall Leadership Board yesterday, so being asked to sign up to the living wage, when I think we pay the living wage in all of our NHS providers because we don't pay below a band 2. Then looking through the rest of our contracts, I think we pay the living wage in all of our care and care home contracts, but we'd need to check and do an impact assessment before we could sign up to it. So we need to, for things that are as important as this, we need to find a way of bringing it through our internal processes. So when we sign up to it, we can actually deliver it. So that would just be my plea. We would want to do it. Let's go away and do the work and make sure we can make it happen.
Patrick, on the living wage issue, because it is a national issue as well.
Nothing to add. I think it's the impact assessment that's the key part that we need to gauge. The principle of real living wage and the evidence of its benefit to population health, I think we can take as read, but it's the impact about how we get there across the complexity of NHS workforce. And that's the same for all the other sectors who are signed up. So we need to take that into account.
Tarn?
And perhaps we can take some of that information through Workforce Committee in terms of real living wage. My other further provocation in that space is that we don't just look at real living wage, but we look particularly for people on long-term health-related benefits with our DWP colleagues about universal basic income.
Okay, well noted. Okay. Oh, Steve, I didn't see.
Yeah, not on that. Just really briefly on the NHS provider partner member update, and then one question for Ali, if that's okay, on the local authority report. Just to highlight the West Cornwall Hospital County Community assessment and treatment unit establishment and operational as one part of the winter plan. CFT and RCHT have been working really closely together to enable that with SWAST and with ICB and community colleagues. So that's one of the pieces of our winter plan, and really positive to see that progressing. Second comment, and Kate referred to this in her opening remarks, all parts of the NHS are urgently required to review their winter preparedness. And I know we've got winter plan on the agenda, but in addition to all of the actions that are set out in the NHS partner provider members, further urgent work's underway now to see what additional extraordinary actions can be taken to deliver the safety that Susan talked about in the summary that Kate described. Currently, the system continues to be under extraordinary pressure. There are about 250 of the hospital beds across UHP, CFT and RCHT occupied by category P1, P2 or P3 patients with no criteria to reside. So that is one part of our system pressure and challenge. And my question, Ali, for you was around the update that the local authority escalation has been stood down with effect from the 20th of October. And just, I know there's a huge amount of work which is underway in the local authority and across the wider sector. Whether you could just give us an update on that and the current levels of escalation?
Yeah, Steve, so that was at the point of writing. I absolutely recognise that that's not the case any longer. But at the time of writing the report, we had stood down escalation at that time as of the 20th of October. But yeah, you're absolutely right. We're not stood down now, and we are. I've spoken to Susan this morning, and I've asked Kate Kelly Talbot to make sure that she links in with Susan to make sure that adult social care actions are reflected in the winter plan that we've got, because I don't think it is at the moment. And we've also bid for some money, some adult social care urgent emergency care money, I think it was titled, which is a bit odd. But we've bid for some money, and I think we should be putting those actions in there as well, pending the funding. So absolutely committed to making sure that we're reflected in our winter plan. We're not at the moment though, Steve, and I appreciate that Susan's done an awful lot to engage adult social care, and we have been at those meetings, but we haven't really got our actions landed in that plan.
Okay.
Thanks.
Thank you very much. Right, thank you everyone. Shall we move on to the next item? Yeah?
Oh, sorry. Sorry, Chair. I wanted to actually make a point on the partners update. I wanted to congratulate Steve on his 2 awards. I thought it was really important that we just recognised that as well. So I think it was for the Critical Care Healing Garden, which I think is amazing, and the Super Clinic as well. So I just wanted to recognise that from the partner updates. Thanks, Chair.
And if I just offer a personal apology, I wish John Evie was here. My new glasses I had to take back yesterday. So anybody past Tarn and Martin, I can just about see you. So rather than, like, if you could just wave a tad at me, we're really, really grateful. But Mary, I did catch you sort of wave then. So
thank you. Sorry, I thought I'd missed the turn. I just wanted to say to you, Ali, thank you for your report. And actually, I found it really helpful. Because we often talk about pressures that are in health providers, but I thought the point in your report where you noted the number of unallocated assessments compared with the number required and that allocated just reminds us of the pressures on social care as well as all the other areas that we talk about. And I don't think I've seen that before. So thank you for that. And I guess my question, if it's answerable, is how long does an assessment take to do? What sense could we get of how fast that could move through?
I mean, that's going to depend on the individual. There isn't a set time, and I know that you know that, don't you? So but what we have done, and I have included some of this data in previous reports. If you look at April last year, we had 1,900 or just under 1,900 outstanding assessments. What we've managed to do is get that figure down and also maintain our run rate during that period of time. So we see that our net improvement is, I think it was 640 in this report. It was a little bit higher when I looked at it on Monday, but we look at this on a weekly basis and we're monitoring. We've also seen significant improvements in people waiting for assessment, for services as a result of those assessments as well. I think there's more that we can do. We don't see all of those assessments result in services. So I think we've got an opportunity to get the resolution for the resident at an earlier point in time. So that's all the kind of stuff that we're trying to do at the moment, to understand, what are the themes, what could we have done differently when that person contacted us, rather than waiting for an assessment for a service that they don't need. And actually we could have signposted them and supported them to access something else at an earlier stage in time. So but thanks for that. That's really helpful. Thanks.
Sorry, Mary. Okay, so nobody else waving at me. Yeah, that's. I can see it now. Go for it.
Sorry, John. I just was reading Jane Milligan's report from Devon ICB, and I wondered if board would like to thank Jane for her contribution to this board.
Of course,
I would certainly like to thank her for her support in my role as North and East ICA Managing Director. As a resident of North Cornwall and as of the Chief Executive of Devon ICB, she has been thoroughly supportive of our work.
All right. Thank you for pointing that out. Agreed. Okay, colleagues, let's move on. So we now move to item 10. So Molly and Carolyn, who's leading on this?
Yeah, so Chair, I'm just going to give a brief outline. This is just a continuous piece of work that obviously we're doing to build and finalise our risk profiles. Obviously, last month the board saw the in-year. This month we've brought the strategic, and I'll try and keep this short. I'll hand to Molly, but just a few key points that we might just want to bring to the board's attention. But as I say, we'll keep it short.
Thank you, Chair. As Carolyn said, this page updates and it's presented to the community, particularly in context
Molly, we can't quite hear you. Can you bring the mic forward, please?
Can you bring it closer to you? Yeah.
Can you hear me now?
Here we go.
Thank you, John. So I'll just go back and recap to the point which I initiated, which was around the fact that this paper allows the board to see an update from the October scorecard. And notably, there is a new objective which was agreed at the workshop and it's presented to the board. It's really important that the board has visibility of it. And it's on page 3 of the paper and it's entitled "To Reduce Harm by Moving Care Closer to Home Where Clinically Appropriate." And on the basis of that, some risks have been identified and they're in Appendix A of this document. And alongside that risk, there are also some proposed arrangements for risk oversight in Section 2 and Section 3 of the paper. Section 2 highlights what the Executive Directors Group will do to make sure that the mitigations, the assurances for identified risks are maintained and monitored. And we're proposing that this process starts from this month to allow board and committee to see the updates from an in-year and a strategic perspective on a cyclical basis. And the next step section highlights all the key tasks that are happening from November onwards, with a NEM and exec risk workshop taking place in December to agree the new in-year principal risks. And they will be then presented every second month to the board and committees as an update. It's also worth noting the last 2 items on the next step section, which are that the cycles of business of the executive directors groups, the committees and the board will be updated to incorporate those risks. So we're going to apply a very risk-focused approach to the work that the committees and the board does. And then latterly, we had started some work in the summer on objectives for risk management strategy. This work today also informs what the content of the risk management strategy will be. So if the board approves the proposed arrangements for risk oversight, they'll be included in that document, which will be provided to the board in January for approval. And the board is just asked to approve the recommendations set out in Section 6. I'll pause there.
Very good. That's pretty clear. Thank you. So this has all been done as part of the learnings of our first year, chatting with all the committee chairs on the ICB and talking with Kate and the executive group about quite how we have this sort of gold thread of governance coming through from the board, its priorities, its risks, it's carried through into the committees, what they look at, and then reporting back into here. And then the executive group that actually makes sure that the papers that actually feed all of that are put in place. So, if it's all right with everyone, please look. Are you waving, Steve?
Yes, I was just hoping there was a chance to make a brief comment. Appreciate there's a huge amount of work which has led to this, and I'm certainly very grateful for that. But not having been part of those committee discussions, I'm not quite sure whether this is the place to comment. And the 2 comments I had, John and Molly, were on the first risk and the final risk, and whether we should think about firming that language up even more. I think the risk that I would see from a safety and quality perspective is the harm that is being done to patients currently in the way the whole system is configured. And the steps we're taking are to address that, to ensure that we achieve the necessary safety and quality aspects. And from a financial perspective, there's the combination, I guess, of our statutory responsibilities to deliver financial balance, which we know from the medium-term financial plan are under significant risk. So whether the framing and the wording of that first and final risk might need to be, or we might consider being kind of clearer and more direct.
You happy to update that risk based on that? Is everybody happy for that? Because I think that's a really important point you've made there. Everybody up for that?
Just for clarity, sorry, Steve, it's me. I mean, you were saying the first one. You mean the new one, reduce harm by keeping care closer to, by moving care?
So if I've understood this framework, that first column is the strategic objective. That's what we agreed. The second column in green is the way the risk is framed. So that's what I'm asking about, and that says the risk that we do not have the appropriate structures and frameworks and evidence to ensure quality. I'm just challenging whether that's strong enough in terms of the safety risk that we face. And then the second one I was raising, again, is not challenging the true north strategic intent. It's just asking whether the way that risk is described, failure to align our financial strategy to support our care model. I guess what I'm saying is that the kind of risks I would see is we fail in our statutory duty to deliver a financial balance. That leads to intervention. We're not able to invest the care that the financials that we desire to achieve our strategic intent. So it's just whether they're described clearly enough as risks.
So if we listen to the national message, in theory we've got more resources than we should have to do what we're doing. So it's not about failing to be able to invest our resources, it's where we invest our resources and the impact of it. So can we take that away? Because I don't want to write something that says we can't meet our statutory duties because we haven't got enough money, because that clearly isn't what we're being told. Yeah. So I'd quite like to take that away and then reshape it so that we're being very clear about what it's saying.
Right, so why don't we do this? Why don't we say now, you take that away, work with your colleagues, and this will be refreshed, Molly, before you change it, and we'll come back to it next time. But we've taken the points and the observations. Neil first.
It's just that I wanted to highlight my slip of the tongue there, which was I said keeping care closer to home, but actually we've written moving, and that highlights what we're all talking about, that we have to move it back closer to home rather than keep it there.
I just wanted to pick up on the person at the centre, which appears on both sheets. I was a bit confused about what we were trying to do there, because for me on sheet 2, where we're looking at the what we want to do about that and some of the things that link to it, that is about wholesale implementation of personalisation throughout and across all of our services and institutions and organisations, and that's as much about service processes as it is about culture and behavioural change in our workforce. So I think that might need a little bit more work, which I'm very happy to support on.
And I'll take that away and refresh this. Again, colleagues, what I would say is don't forget last month and this month was the first iteration of the new focus. So that's part of the reason why, Molly, you've got the executive group coming through, structured in here to be able to come back with changes. Carolyn?
I was just going to say, if anybody, we said this last time, but I'll say it again, if anybody has any comments when they're thinking about it, please can they send them to us? We did ask for the last time, but we didn't actually receive anything. So that would be helpful.
Cool. So let's move to the recommendations, everyone. Agree the process of maintaining oversight. The executive is set out in section 2 of this report. Are we happy with that? Yeah. Approve the process outlined in section 3, maintaining the board committee level and biannual alternating between risk and in-year. Yep, that fits with the structure. Thank you. Note and receive the draft strategic principle risks attached. So what we're going to do here is we'll just say in the recommendation of the outcome of this discussion is that we're going to ask Kate to take it away with colleagues and refresh that and come back next time. But I do think point 4, if you think about it, is at the crux of this. There's no point identifying the risk if you actually don't have the mitigations. And certainly committee chairs, if I can reach out to you, you won't be able to scrutinise if you actually haven't got the trajectories Kate, that we said we would have coming forward, and the plans and the level of detail against each of these risks. If you don't have that, you can't scrutinise. So those need to be in place, please, and the mitigations for the next review. Molly, is that okay with you as a paper?
Yes, thank you.
Happy with those recommendations? Carolyn?
Thank you.
Done. Let's table that. Thank you very much, colleagues.
Sorry, Chair, there's one
Yeah.
last recommendation.
Oh, did I not turn the
Page
page?
one.
Turn the page, note to self. Okay. Oh, yes, we were going to ask the audit chair to bring back to the ICB board in February the draft audit plan for 24-25 and how we intend to ensure we maintain oversight of the governance processes that we have in play. Martin, I assume you're happy with that? I can't comment on it.
Yes, completely. I mean, the audit plan will give an overview of the whole process, and I would hope also that each committee will be keeping some sort of oversight of the data that's feeding into it, and the meetings are feeding what they need, but we'll certainly check up on that.
Now you're more formally ensconced with us, Molly. You can help us on this journey, please. Thank you very much. Colleagues, I know we're running slightly behind, but I hope you feel it's been of good value having the debate that we've had on this. And I don't want to shortchange this next section either, because this is about the urgent in-year stuff. I know this is a strategic month, but given the fact that strategically we've got to actually make sure we have a good base to start from in terms of winter. So again, even if it eats into a bit of this afternoon, I think we need to have the appropriate level of discussion on winter that we need to have. Is that right with you, Kate? All right. So if I can hand over to Susan to lead the discussion on the winter plan, please.
Thank you, Chair. So I'd like to start, you have got the slide pack in front of you, and some of you are probably looking at it and thinking it looks quite small and brief. However, what I would like to just set the scene with the winter plan is this needs to be taken in context with the work that we've been doing around the intermediate care strategy, of which the first phase we all agreed would really make up a fair amount of the winter plan. We also have work that's ongoing with Deloitte, particularly around flow, that targets falls, frailty and end of life, all very much integral parts of the winter plan. The other thing that we need to take account of with the winter plan is the fact that as a system we are in tier 1 for urgent and emergency care, and we've also had GERFT come in and do a review of our UEC. So all of that information we've tried to capture throughout the winter plan. So we started winter planning in earnest in August, and we started with the ICAs, and it's been really interesting listening quietly to all of the comments that have been made, because we can pull it all back to the winter plan and to some of the discussions that we'll have a little bit later around clinical strategy. But there is another point that I would like to make, and we made it at the last board, about how we as a group of senior leaders make sure that all of our teams are fully informed. So Ali and I talking this morning about the fact that we haven't got enough in the winter plan from adult social care. I feel as the SRO for winter, I'm engaging everybody, but it's making sure that we're all playing our part as senior leaders. We're getting information out so that we can get information back, so the winter plan is a fair reflection of everything that we want to do, because there is so much that's happening. Neil said it, Emma said it, everybody's said it. Kate mentioned me going out and about, had a great day going out and about, went to one of the community hubs, talked to some of the people that are running the pain cafes. Some of the statistics that are coming out of the pain cafes are phenomenal, and we need to mark them here. So we will do that piece of work, Emma, because that very much focuses on our clinical strategy and our joint forward plan around personalisation, prevention and place. And we're trying to pull those threads through everything that we do, not least of all the winter plan. So in opening this up, the winter plan will be iterative, and I think that's an important point to make to start. And I've already got another recommendation that's not on the winter plan that we need to make in view of the last 2 weeks, particularly because the winter plan was written in readiness for the board. We managed to spend a little bit of time out in SAG, but nowhere near enough the system executive group. So I think the winter plan is something we need to keep bringing back. We'll take it through our quality committees because it's iterative, and we've all signed up to quality improvement and our PDSA cycles. This is a brilliant example of how we're going to do that and how we're going to land it. However, in saying that, we did have 4 key areas that as a system, when we did our first winter planning, we all agreed admission avoidance was a big objective for us across Cornwall and the Isles of Scilly. Increased, it says hospital flow, but that's flow not only through our CHT, it's CFT, but it's all through all of the caseloads that we have working alongside our bedded capacity, whether that's in mental health, whether that's in STEPS, Home First, district nursing, community matrons. That flow has to go right the way through our system. We need increased discharge capacity, and I have to thank Adult Social Care, because the work that's been done, particularly around P3, has reduced some of our P3 weights by up to 50%. We know the issue still sits within dementia, and we've got a lot of work that we need to do around dementia and supporting our care home sector with looking after people. We know that people with dementia sitting in an acute trust actually exacerbates that condition and is a very, very poor experience, not only for them, but for their relatives as well, and for our staff. And that feeds in to our workforce and how we use our workforce, how we place our workforce, and what we do more of. So the increased capacity, we've also focused around P1. We've increased P1 capacity, but as we keep saying, we can put as much capacity in as like, we'll continue to use it. So there is something around that emission avoidance in the first place, wrapping around within people's homes, within their communities, that avoid some of those admissions that will become tomorrow's delayed patients because of the care and support they'll need around them. And we are working, we've got work that starts this week around our P2s. So those are the people that need more than packages of care, that need some bedded care, but also include our stroke patients, and that we know with this particular season, we see our stroke incidences climbing, but we've also got the added challenge of stroke being categorised as a Cat 2 for our ambulances, and we know that our Cat 2 mean times at the moment are nowhere near where they need to be. Yesterday we were running at 2 hours and 20 minutes. Our Cat 2 mean time should be 18 minutes. So there's other challenges that are impacting on the work that we need to do through the winter plan. And one of the areas I'm really pleased to talk about, and Lucy and the team and the wider comms team throughout the system really need to be recognised for the work that they've done today. The comms plan that we've got for this winter is probably one of the best comms plans that I've seen. This will be my 6th winter in Cornwall, and it's really proactive. It's reaching into communities, it's reaching into the hubs, and it's talking to groups about what matters to you, what works for you. Because we know, and we keep saying it, but it's not landing. We are doing harm by admitting some of our elderly population into the acute trust. But when you're faced with a situation either as a paramedic or a GP and there's no other alternative that you're aware of, it's the only building, we keep saying, that has the lights on 24 hours a day, 7 days a week. So we do have to reframe our thinking and reframe our risk appetite, and have confidence, absolute confidence. I would like to say that some of the things that have been done through our MIUs in the last couple of weeks are astounding, and I wouldn't wish to divulge any patient confidentiality, but there's been some astounding things that have been achieved through our MIUs. So we have a very skilled workforce. We need to trust them to do the work that we've asked them to do, and give the acute trust a break to be able to get on with the work that they need to do as an acute trust. This is what the winter plan sets out to do, but it is iterative. We do need to keep reviewing it. And the way in which we're going to review it will be through our SCC, our System Coordination Centre, every Wednesday. If I don't chair it, it will be Chris. And I hope that's not a surprise, Chris. So we will do a lessons learned of the week, how we manage what we've done that week, what's worked, how we take it back to our winter plan, and all of the objectives that we set within the winter plan. But also, if you look at the plan on a page, which I think is a helpful summation of everything we do, those principles that we hold dear, which is about patient safety, patient experience, not only the experience of our patients, but again of their families and their loved ones, watching people go through our systems and trying to navigate our systems is incredibly difficult. So those principles are really important. We talked, and Neil said it, about making sure that what we do as much as we can around a person's home, around their community, around the people who know them best. And only really in extreme circumstances, do we then consider whether or not they go to, or appropriate circumstances, they go to the acute trust? There is so much that we can do for people at place. We've invested an awful lot of money in our urgent care response services. We need to make sure that works. And I mentioned it very briefly in the update around quality. We've got the Care Coordination Centre. I think this is really exciting. It's not something we've seen before in Cornwall. And we are a step ahead. I've been told this reliably because we had something called the ITK line. And I know you're going to ask me to say what that stands for. And I can't remember off the top of my head. But what the ITK line does is it reaches into the ambulance stack. So the people that are waiting for an ambulance, and starts to pull people out that we know then that don't have to wait for an ambulance, that don't end up unnecessarily at the front door of our ED department. So we are a step ahead. What we need to do is make sure that we're wrapping around all of our services into a coordinated way so that we can dispatch people quickly. And our UCR colleagues are telling us there's more they can do and more they want to do. So we need to harness that and work with them. I have to give praise to the voluntary sector. They've done phenomenal work and they continue to do so. And I think it's absolutely the right thing to ask that we bring a piece to board chair around the work that the voluntary sector is doing and continues to do and can do more of. We cannot underestimate social prescribing. I think it's a huge bonus to people, and that's part of that personalisation. What matters to me, shared decision making is something that we're getting better at, but there's always more room for improvement. Particularly in the winter plan. We have set some fairly ambitious targets around our no criteria to reside. These are people that are in hospital or in the community and don't actually need to be there, but they're waiting for something else to happen. We as a system, we did it collectively, collegiately, set targets. We are now saying, given the last 2.5 weeks we've been in Opal 4, we maybe need to recalibrate those to be more realistic. That doesn't mean to say we are stepping back from our ambitions. What we don't want to do is set false expectations and false hope. So those no criteria to reside are very much dependent upon some of the work that we've done around boosting the P1 market, the work around P3, and now the work that we're doing, particularly in brokerage, around P2. We know that we've got some more improvements we need to make, particularly around stroke for that P2 market. So those no criteria, please don't take the message that we're pulling back from them. I just think we need to recalibrate them in view of the situation we find ourselves in. We've got some work that we did with Deloitte and with RCHT around what would happen if we didn't do very much through the winter. And for that would mean an additional 89 beds. And we know that we haven't got 89 beds. However, what we have got and what we're trying to work through as a system is a narrative that instead of talking about beds, it talks about services that would replace a bed. So our virtual wards is a really good example of that. And we know that we've got good capacity in the virtual wards. We've got very skilled people. What we need to do is instill the confidence in some of our clinical decision makers, whether they're in the hospital or GPs in the community, that the virtual wards are a much safer option than somebody on the back of an ambulance for over 12 hours. And sadly, we have had a patient on the back of an ambulance this week for well in excess of 12 hours. Not a great experience for anyone. So we have put the mechanisms in there that starts to cover off those 89 beds. The work that we're doing with the urgent community response will also offset those beds. So what we will do, Chair, is keep tracking through the SCC how many of those 89 beds we can compensate for. Some of that will be around the work that Steve's team's doing and Debbie's around average length of stay, because we know for every half a day you knock off, roughly, it's about 40 beds, give or take, depending on the pathways. But that's quite a big number when you think about the beds that we are going into the winter potentially short of if we don't land our actions. I've put into the slides some of the actions, but they need to be seen in the wider scope of the work that we're doing around intermediate care and the work that Debbie is really ratcheting up around Deloitte's with Flow, that's end of life, frailty and falls. We've got a fantastic response now to falls, and I hope you all agree we are not seeing those headlines anymore in the papers about people with long lies. whether it's on a pavement. We had one that was in Newquay Airport last year. I mean, that was a particularly low moment. We're not seeing those stories, and we're getting really good feedback about the falls cars. I'm having conversations about the tri-safety officers and how we extend those offers into the community that starts to really help build on that Brazilian model that we've talked about many times at board. Again, we will continue to review these actions. We are looking to put an X-ray car down in the west. We've heard that the evidence is there that will help if it avoids older people having to go to hospital and waiting and decompensating, then I think that's a great thing. But again, we're putting key performance indicators and harm metrics around anything that we put into place so that we can review it, so that we know that we're getting a return on investment, not only for money, but also for safety. Okay. I'm happy to stop there because I think there's an awful lot of questions that will probably come our way.
Just to give everyone some perspective, you mentioned at the start you had another recommendation. Why don't we just hear what that is now, and then we can.
So the recommendation is to accept the winter plan in its format, but understand that we will be recalibrating some of those targets that we've set, and we will be continuing to iterate the winter plan as we go through those weekly meetings.
So we'll come back to it when I get to that section. Kate.
Yeah, I just wanted to pick up a few things that came out of the meeting that we were at yesterday that reads directly to our winter plan. So we are being asked to look at whether we would call before convey. And I noticed we haven't got SWAST with us today, and I don't think we've got them online today either, which is a shame. So there is something about whether the range of alternatives that we've got could be discussed with a paramedic crew before they convey people to hospital. And that diversion, if we divert 9 frail people from coming into our CHT with an average length of stay of 8 days, that's 70 beds this winter. So if we go back to 89 beds being our shortfall, that's an awfully big contribution towards it, and it probably will have better outcomes for those people that are streamed away. The second is around streaming at the front door, because we know that without having fail safes in the system, that people will end up in our CHT who perhaps it isn't the most appropriate service for them. So how we compassionately stream people somewhere else, and the comms that Lucy's been looking at and preparing to go across the whole of Cornwall, how we inform our people around making great decisions for themselves and their families. The third bit Susan's alluded to, but this the single phone number for logistical deployment of alternatives to going to either general practice, an MIU or ED. So we need to very rapidly get that single point of access in place for winter. I think I'll leave it there. Oh, that's the other thing I just want to say. I'm looking at our actions that have been taken. So in the meeting I've emailed Steve, so he won't have seen it. But the West Cornwall, the X-ray car, there are going to be some things that are going to challenge us around our readiness to be able to engage with things that we're asking to do. So the X-ray car's already been trialled in Cumbria. It's not really a trial. It's just, is Cornwall ready to work in this way? We've got everything geared up, but we need to know that the radiology service in RCHT is able to deliver the car, because we think it'll give great merit for care homes and for GPs to make alternative choices. But we need to know that the whole of our system can work in concert. So how we do that, and I'm only using that as one example, there will be others in here that will cause all of us at some moment to think, can we do this? We're using other people's evidence. There is nothing in here that's prototyped. So if other people have done it, there should be a reason why we can too. And we need to hold ourselves collectively and compassionately together to be able to do the best this winter.
Thank you. Stuart and then Debbie. Stuart?
Yeah, thanks. I mean, that plan's, there's some great stuff in there, isn't there? I just wanted to pick up on one bit from a general practice perspective, which is the ARI hubs. So it says ICA or ARI hubs in each ICA. So the problem is that, particularly in poorer areas, general practice gets overwhelmed by acute respiratory and ENT illness over the winter. It's not unusual for me and my colleagues to deal with 100 to 125 patient contacts per day on call. And generally that is minor illness. And when my time could be way better spent on making difficult decisions to keep people out of hospital or proactive preventative care. And the ARI hubs, from my understanding, are not realistic this winter. because there just simply is not the workforce to staff them. But there is a consensus across general practice, particularly in the more sort of urban areas. Rurality has slightly different poses slightly different problems, but that ARI hubs would make a huge difference. Therefore, siphoning off some of the more minor illness type stuff into, say, Rs or UCP roles, and allowing our experienced GPs to support the system by keeping people out of hospital. We are going to pilot something in St Austell this year, but it's going to have very, very minimal impact. It is very much a test and learn situation, but it's just to highlight that part of the plan I'm not sure is going to come to fruition this winter.
I think Debbie might be coming in on that.
Debbie?
Yeah, so I can come in on that, but I also had some other points to make, because I think I'd like to follow on Susan's lead to talk about alternatives to the emergency department and
In which
the
case,
acute.
just bear with me. Do you want to answer Stuart's?
So shall I speak to the ARI?
Yes,
hubs
sorry, you can speak to that first. Yes.
Yeah. So, at the present moment, we're looking at what can we do for this winter with the workforce that we currently have, and how can we optimise that. So yesterday, I'm actually welcome Stuart's intervention there. So yesterday, Andy Sant and myself and Dale from who's the clinical director for Bodmin, met with our team locally to talk about the ask for an ARI hub for winter and what could we scale up. So we as an organisation have committed to, where we have the workforce to do it, the existing workforce, how can we make that model work? What we've heard from primary care is, please don't overpromise and underdeliver, because this is a booked resource that can go in. So whilst at the present moment we don't have the advanced nurse practitioners across the entire county yet that we could offer this, where we have trained them as part of our workforce strategy to upskill people, we are looking now to implement for winter. So it's not solely county-wide, but where we have got the staff, we will attempt to set it up.
Stuart, was that a grimace I saw? Did you want to comment?
No, it's not, because obviously you totally recommend, recognise any development in this effort. I would say that, they'll be situated in places where there is already sort of urgent treatment capacity, and that isn't much use to Nick's patients in Falmouth, or my patients in St Austell, unfortunately, or in Newquay. And so I think certainly need to recognise as we go forward in this that deprivation plays a huge impact on respiratory illness over winter, and really the offer has to be broader than the three existing sites. Although of course we all recognise that any progress in this space is very welcome.
So what we're going to do, if it's right there, and we'll go Kate to respond. Deb, if you want to have another opportunity, and then we're going to go to Steve.
So there was a piece of work done by our regional public health colleagues around acute respiratory admission and admissions, acute respiratory infections and admissions for this winter. So they've segmented our population for us. So we should be able to use that information, and it bears down to your point, Stuart, but it even gives us the age group. So we're going to be the people, I think it's 18 to 25 year olds and over 75 who've got limited household incomes are the ones that we should be targeting, and they can tell us which part of Cornwall they're in. So in terms of matching our resources against where we've got the known groups of people who are likely to deteriorate the fastest, we should be doing that. I know some of the primary care respiratory nurses in general practice have spoken to me as individuals, not as a collective, to say that they perhaps feel they could do some more if we invited them to be involved in some of the targeting of resources against acute respiratory infection. And then my third point was around the use of our respiratory virtual wards. So one of the other things we were reminded yesterday was during COVID, we were all really clear what we were going to do, what we were going to target, what would have to wait in order to be able to deliver safe and effective services. And I think there is something about how we use our respiratory infrastructure this year in a way that we can segment it all the way from self-care through to the virtual ward, through to the clinics that we'll be offering. And maybe we need to go back round the loop on that. So I don't know, Susan and Chris, whether you would pick that up following the meeting, just to make sure we've got resources deployed in the most optimal places. And Rachel, whether you would be happy for somebody from your team to be involved in us targeting it.
So a number of people want to comment. Steve, is yours on this point? Fine. David, did you want to respond to Stuart, or are you happy with where we're at?
Could I just add on the respiratory virtual ward? So looking at the data, we are getting patients through the respiratory virtual ward, but it is about 50% occupied.
Yep.
So there's actually quite a lot more to go for there.
On this point, Chris?
Yeah, and it's just, I'll probably pick this up with Stuart and Nick through LMC and Collaborative, but the primary care team have been trying to make sure we've got a bit more flexibility with the PCNs on the various funding streams that we've historically had for extended hours and enhanced access Saturday clinics. And it was really around making sure the PCNs have their own flexibility to design what they see fit. So I just want to make sure that message is getting down to Stuart and Nick. So I'll follow that up offline.
On this point, Emma?
Absolutely, yep. So we know that the reasons why respiratory exacerbation happens is because of a whole range of other factors, including poverty, lack of food, lack of heating. So what do we need to do to join up the health response with organisation? I mean, thinking like the Brazilian team, anybody who's down on the ground, community hubs who need to be picking up some of that prevention work, perhaps targeting that with the data that we've got access to.
Mary, on this point?
And could I just add to that, and housing and the mould factor and all, because there is a huge number of housing organisations that we need to be having collective.
Point, Rachel?
It is. It's so there is targeted work that's gone on around cost of living. So it relates to what Emma's saying, but not just respiratory, but people who have low finance at risk of debt and cost of living in cold homes. So there's a bit of join up between community work, as Emma said, and the winter plan. It doesn't need to sort of specifically sit inside this plan, but I think recognise there's a whole range of work where that's about debt, about making sure people have adequate income. And that's also using data targeting households. So I think there's a conversation outside of here around how we make sure that we understand those two approaches and get best value from them.
Very good. So before we move on from this point, did you want to raise something? Oh, a separate point. Did you want to, before we move on to Steve, anything on this point?
Yeah, can I just summarise then, because we talked about a load of stuff there. So there is something about aligning the winter plan with the broader work around cost of living, because it's the same population actually that we are focusing on. And then the second bit, Stuart, thank you for your intervention about the acute, I can't say it, the acute respiratory infection hubs, that we need to pull all of that together again, don't we? A, make sure they're in the right places. B, put a sufficient flexibility into general practice so that practices and PCNs can work together to make sure that their resources are able to match the need they'll be seeing. 3, look at the additional things that we've got through both CFT in terms of specialist staff to provide clinics, but also specialist facilities like the virtual hubs. Align that with our respiratory teams. So we've got maximum management of a cohort of people with a condition. So it's almost the antithesis of what Neil said earlier, that people aren't conditions, but we know that acute respiratory admissions will really push our CHT's admission rates as we get through winter. And it's a hospital that doesn't just deal with people who've got breathing issues. So we need to make sure that we maximise every single asset we've got across Cornwall. So Susan and Chris, can I ask you to pull together a very specific plan around acute respiratory infection? And Neil, can we test it through PCCC? And also, can we make sure that our providers, RCHT, UHP and CFT, are sharing their resources across the system so that we've got maximal impact this year?
Okay, thank you. Steve, thank you for being so patient. Next point.
And I strongly support Kate's summary. I think that's really helpful. Ali, I'm very grateful for your suggestion earlier on that this plan includes the significant range of work underway to enable the P1 and P2 capacity, particularly, and there's a P3 component to that as well. John, not wanting to be difficult at all, but I wonder whether I might suggest that rather than kind of agree this plan now, we note the huge amount of work which has been undertaken. Susan, I think you've steered that really, really well. But I think we need further actions, and Kate's described some of them. I think it would be more appropriate to ask all of us, me included, to do further urgent work in the next 2 weeks so that we capture the summary that Kate described, and any other extraordinary escalation actions that we can take, so that by the time we get to the 22nd of November, we can see the totality of the actions that we're taking. We can have the clarity on the impact that they'll have, and we'll have the accountability mechanisms to ensure each part of the system is delivering against that plan. So it's supportive of the huge amount of work undertaken, but I do think we need to move that further.
Before I bring in Rachel, Kate, have a think about how we respond to that. But just explain to everyone the relevance of the 22nd of November.
Apologies. NHS England, recognising the challenges that all parts of the NHS face going into the winter, have asked and required systems across the country to do further urgent work to ensure that every part of the NHS is prepared to deliver the safest winter that we can, to eliminate waiting times for ambulance handovers, and to deliver that in an environment that delivers financial balance and progresses the elective activity. So there's a national component which is absolutely aligned, I think, with our local timescale as well.
Thank you for clarifying. I didn't know how many of colleagues knew that, because that's actually come out since the papers came out. So I thought it was just worthwhile. It came out last night. It's showing that. Rachel.
Yeah, yes, fully support the need. There's more to do. I suppose also someone who's chairing the tier 1 meetings with the system. It's holding the nerve with the things that are doing well. And my reference would be things like early discharges before 12. There's beginning to see the first green shoots, but there could be more. So it's also driving on the things which have impact in terms of releasing flow in the system. So it's not necessarily more things add to. It's also just really now driving the things that because you've seen the impact already that could make the difference.
Okay.
That's Margaret.
Oh, Margaret, sorry.
I just wanted to understand if we have a good eye on the capacity for discharges, so domiciliary care places in care homes. Do we have a really good view of what is available? Do we have unused capacity? Do we know what capacity exists out in the system and how we're utilizing it?
Kate and then Ali has indicated. So
I deliberately wanted to go before Ali because we have there's a care home tracker that everybody fills in. It isn't always up to date because sometimes those beds have been filled after the tracker have been filled in, and sometimes the tracker gets filled in when there are beds available but they're not staffed, so we could use them but they've been able to look after people. So the numbers that Susan went through around our P1 to 3 discharges, P1s are starting to really crack on, and we know we've seen some recent improvement on P3. Our biggest issue in Cornwall is care homes who will take people with a diagnosis of dementia. And we did have a large care home provider that did take people with a diagnosis of dementia, and they don't anymore. And that's a massive gap in our infrastructure for being able to discharge effectively from hospital. So
from all hospitals.
Yeah, from all hospitals. Yeah. And I think part of what Susan was saying is that we sometimes make dementia worse by keeping people in an institutional setting. So if we move people out faster or avoided the admission, we might slow down the P3 need. But yes, you're right, we've got a big hole for long-term care in a care home for people with dementia. Ali?
Yeah, I was going to say something really similar to Kate. So we've got 5,086 care home beds across Cornwall. There is a mix of those. That some of them are nursing, some of them are residential, some of them are dementia. We buy as a sector, health and care sector, about 50% of those beds, and the rest are being sold to other people, other local authorities, other NHS buyers, and also self-funders. And it's the same with the domiciliary care market. The only complication with the domiciliary care market is you don't have the beds to count because everybody's in their own beds. So it's about how do you optimise the capacity that we've got, and it changes on a day-to-day basis based on, how many staff somebody can recruit. So it's quite complex. What we are doing through our retender of our dom care contracts, and again, we're 50% of the market, is we're trying to allocate those areas so we absolutely optimise the time that staff are working and reduce the travel time, because we've got a map that shows the journeys that people complete to deliver domiciliary care in Cornwall, and it's like Spaghetti Junction but worse. And at the moment, the latest figures that I've seen, it's about 13 million miles a year travelled to deliver dom care. across Cornwall. So also as part of our carbon neutral plan, we are trying to really optimise the journeys that people travel, but also free up that time to deliver care. The site of the capacity in the dom care market is much more opaque for us as a system than the beds because of those reasons that I've just described. So I think there is a challenge there. We're doing a huge amount of work with our providers though leading up to our retender, and what we've seen is a significant improvement in uptake of our packages of care. So people are waiting less time for long-term care packages. So I'll give you an example. This time last year, there were 34 people delayed at the back door of Home First. There was about 34 people also delayed at the back door of Steps, which is our reablement service. And those are people waiting for long-term packages of care. I looked at the data yesterday. We had 5 at the back of Home First, and we had 8 at the back of Steps. So we're seeing that throughput move. And I know that we've got some queries, Debbie, around our data and making sure that we know where people are in that pathway and that interface back to social care. But the measurement compared to the measurement last year is the same measurement. So we can see that that's improved.
Okay.
But we don't have massive sight of that kind of capacity in the market. Last point though, Chair, if you can indulge me, it's really important that we get reablement and recovery opportunities for people though, because what we're still seeing in Cornwall is a lot of people going directly to long-term care provision without that opportunity, which is why that intermediate care strategy that Chris and I own and the delivery of that is so key to make sure we make best use of the resources that we've got. Thank you.
Thank you.
Thank you, Chair. There is a very important slide at the end of the deck, which I was waiting to discuss, but obviously we didn't have time, but I was just going to recommend that so the board understands risk exposure and risk tolerance. A risk assurance summary around winter plan would be really useful to consider alongside the paper.
Everyone supportive of that?
I'm sorry, Chair, I couldn't hear.
Can you say it again into the...
Oh, yes. Apologies. So essentially there's a slide at the end of the presentation on residual risks, and I was going to recommend to the board that we actually instigate a risk register or risk assurance summary to support the winter plan. So risk tolerance and risk exposure is understood as part of decision making.
Everyone happy with that? Sounds sensible?
Yeah.
Thank you very much.
There's other risks that aren't captured on that.
Yeah.
And that was why I was just, these are our known risks at the time of doing the paper, Margaret. There are absolutely no risks. And Chair, just to be clear, in answer to Steve's point, it's why I caveated at the start of the presentation, the winter plan has to be an iterative piece. But we have to produce something to bring to board. But I am well aware there's more.
And I will come back to the 22nd of November in a second at the very end when we get to recommendations. Final word, Kate, and then we'll draw this to a close.
I suppose it's whether we can be sufficiently agile to move our resources around as the different things that manifest over winter happen. So acute respiratory infection will come at a certain point. We may then have, I don't know, more frailty fractures. We then might have a greater need for P1 going home because it's cold and people need to get back on their feet. So it's how we collectively use the resources we've got to meet the different needs. And almost, I think if I'm right, on a seasonal perspective, Joe Davis can sort of tell us which thing's going to be our bête noire at each point of the winter process. So we probably need to map our plan against what's coming and making sure we've got the right people in the right place.
Okay, thank you. So, Susan, we'll come back to your final set of recommendations in a moment, but the recommendations in the paper, bearing in mind this was written a week ago and we had the letter in last night, and that was the date of the 22nd. I'd like to make a suggestion, first of all, and then we can come to the others, which is that we actually ask, through Kate, to come back and delegate to you effectively an update to this, to go back to NHSE and to region by the 22nd of November.
Yep.
All right. You'll be happy with that because that's what we've got to do. That will have enough granularity that we'll be able to go into ICB committees, I assume.
Yep, absolutely.
So noting that if that happens on the 22nd of November, we have almost the week after, I know Sanj isn't here, but Neil's here from Quality. We've got our FMP and our Quality committees that follow almost immediately after those. If I could ask the two chairs of those two committees to spend as much time as you can scrutinising that as you go through there. So when we come to the 15th of December's board meeting, you too can come back and give us, from a non-exec perspective, your assurance that you think the plans that we've put in place on the 22nd are as robust as they need to be. Just before I You, Simon. Neil, are you happy with that? Yeah. Martin, on behalf of Sanj, are you happy to take that away into FMP?
Yes, and just to, I suppose, pick up on the last point that Steve made around that would include a sort of delivery plan, you know, timescales, people involved, you know, the sort of the hard edge of it, as well as just the
Look to Kate and yes is the answer to that.
Yeah, so what happens when plan?
Yeah, the hard delivery plans I've had to minute. So Simon.
I was just going to add to that, and Rachel may want to clarify. My understanding is in the 22nd of November submission, which includes assurance around finance, position on ERF, and how we're going to improve our position there as well. It requires board sign-off. So my understanding is that we will, as a board, have to get together on an extraordinary basis to sign it off as part of the submission up the line.
For the 22nd?
Yeah. Yeah.
Okay, if it's in the letter, we will do that.
Yeah.
Yeah, obviously.
I'm just going to say exactly that the operational guidance, which came out late last night, requires formal ICB and trust board sign-off of key finance performance and capacity commitments by the 22nd of November. We're expecting a template to be issued to give a standard way in which the 42 ICBs and system colleagues can report that back. And I'd understood that company secretaries were looking to look at what the mechanisms might be, because the sign-off, I think, in this case is required by the ICB, CFT and RCHT, not necessarily by other organisations at this stage.
I get that.
But that clarification only came out late last night.
So Molly, can we look to you to liaise with colleagues at CFT and RCHT and come back with a plan of action that gets us to the 22nd of November that meets all the requirements as asked for? But you're going to lead on this from an executive perspective. Susan, anything other recommendation that you feel that you want to add to what I've done?
No.
Are you happy with that? Colleagues, are you happy with this? Again, I apologise if we've gone over time, but these are pretty fundamental issues, so thank you. So we'll move on. We'll move on. So Susan and Caroline, if I could just say on the next one, which is surge and escalation, it might be easier if I sort of say effectively what we're doing here is that particularly as we enter winter, that the idea here is that we assure ourselves that we actually have a surge and escalation framework that is in play and working. And the idea is to effectively go through the executive group through Kate for you to come back and give us assurance as we go through back in January. Is that effectively what the same? I'm trying to make a bit of time up. Is that?
It is, but also the caveat with this, Chair, is that we've got a national Opal framework that comes out on the 3rd of December.
Yep,
so
sorry.
we will be changing again. So the paper really is just to give some assurance around what we do now and how we do it.
Yeah. Karen, anything you want to add?
No, that's fine. Thank you, Chair.
Any questions or challenges?
Nope.
Just a question from me, Jonathan. Apologies. I wasn't clear which committee it had come through. I think we'd had an intent that anything coming to the ICB would go via SEG or go via one of the ICB committees. So I might have missed it, but I wasn't clear where it had been.
It's come from me, principally, on trying to get assurance from here. So I guess I put this in at the last moment to try and ask the question that we had a process for assurance, that the non-execs of the board had assurance that this process was there and working.
So apologies, John. Are you looking for comments on this, or are you presenting it?
No, I guess the reason why I introduced it, as I was the person to ask for that to be put it together, was on the basis that I'm not asking for, is it working now? I wanted to note the fact that effectively what we were doing was going into a review of, do we have a surge and escalation process, and to invite people to come back through the chair of the quality committee, which is Neil, at the January board meeting, and noting the fact that it's actually going to be a change of events anyway in December. So I was just trying to raise the spectre now of, have we got this in play, and what's going to change, and get assurance as we go through our committees that this is working and functioning. Rachel, you wanted to comment?
Yeah, I suppose I'm just thinking, in a sense, it dovetails to the winter plan, doesn't it? Because it's how the system deals with escalation. So just to your point about the governance for the refresh of the winter plan, it could also include the revised escalation framework. It's a really important factor for us in how the leadership and the system work together around escalation. I think you're absolutely right to flag it. The board need to own that as well.
Either way, I said myself, it's come from the non-execs of the ICB wanting to see search assurance. So it hasn't gone through a committee, it's gone through the non-execs effectively to try and get here to do this.
So perhaps if I could make a very brief comment, I think the leadership point is really important, and the governance point is critically important. There is a distinction on the attendance at Gold Command, and talks about CFT and RCHT at a chief executive level, which is of course right. Doesn't make that distinction at a local authority SWAST another level. And I think what I would look for as the NHS partner provider member in this kind of escalation is that we have chief executives or their nominated deputies that have the authority to act in a Gold environment. So the framework itself is absolutely right. The only question I had was around the leadership component that Rachel has just
Let's pick that up now. I'm happy to have the discussion. This is critical as we go through winter. I assumed it was going to change again in December from what I'd heard. So, but where are we now? From your perspective?
So Steve's point's right. So if we hold a Gold, it should be at chief officer level, or the chief officer's nominated deputy, and they should be able to commit resources from their organisation as part of exceptional things we need to do in order to dissipate risk and harm, because that's why we're having the Gold call. So that's Steve's point, and we don't always have chief officers. So at the weekend, Steve, Debbie and I, if there's a Gold, our weekend gets broken every week. Twice a weekend if we have 2 Golds in order to chair a meeting or to be attendant at it.
So could we just go one stage slightly further? Which organisations aren't sending their senior players?
So we will have variable attendance from organisations, whether that be local authority, SWAST or others. If we were looking for comments, the only comment I would have is what Kate has just said, that the organisations should be represented by the chief executive or by a nominated deputy who has the authority to act on behalf of the chief executive. It's just a different form of words, rather than say, for CFT, it must be the chief executive, and for SWAST, it could be any other person. It's a more, we need the leadership commitment.
So just before I bring in Margaret, is that something which, I mean, I was going to wait until to January to get that feedback from. Is that something that you feel is so important, it needs to be done now?
I believe it's a core part of our winter.
In which case, we won't finish this until we have that debate. Margaret?
My point was, it's got to be the nominated person. It doesn't have to be the CEO, but they have to have the responsibility, and it should cover everybody in the partnership, because it's not fair to Kate, Debbie, you're speaking that they're always have their weekends broken.
They have to be able to commit resources. That's the bit that's important, not turn up to help. Because we often have people say, we can help, or if you'd like us to loan you, or it's a committing resources in order to serve the function of reducing risk. And so we just need to be really clear, when people turn up, that's what they're there to do.
Does anybody disagree with that? Any other partner? Ali?
I think I should come in there, Chair, because there's clearly some points being made here about the local authority. So I just want to make a few points. So I'm the Chief Officer for Adult Social Care in the local authority, and Kate Kelly-Talbot is my deputy. Kate Kelly-Talbot will attend the Gold meetings more often than not. And this tends to be because sometimes, and I appreciate they're in the diary at the moment, but sometimes they get stood up at very short notice, and I don't even see them until I'm out of some of my meetings. And you know, that's just the way it is, I'm afraid. And even when they're in the diary currently, if they get stood down and I've rescheduled my council commitments, it's very awkward to put those back in. On the weekends, we have a senior manager on call who attends those meetings. We also have a DSO officer for the local authority. I was the DSO officer a couple of weeks ago, and I got a heads up that we were going to have a Gold. I didn't get an invite. So, and I was waiting for that. So, I mean, if I'm on call, I'm absolutely happy to join the Gold call on the weekends to support the senior manager. The senior manager has delegation around what she can commit budget-wise, and she can always contact us out of hours if there's anything that needs escalating any further. Kate Kelly-Talbot's the budget holder for adult social care, so she has the delegated authority from the council to make those decisions and allocate that resource accordingly.
So Ali, that's really useful. And I think one of the things we should set up, Susan, is a WhatsApp group for chief officers, because we had to delay a Gold a couple of weekends ago because I was in a shop shopping. I was going to say which one it was,
Other shops are available.
I didn't see the text because I don't have notifications on my phone. So can we set up a chief officers WhatsApp group so we can let people know with advance warning? And we will need your advice then around how we manage local authority representation at weekends. so that we can make sure we get the right people in the room. But we'll amend that.
Can I just check, are the senior managers ringing in? Because I'm aware that they do. And I know, Rachel, you covered one a couple of weeks ago and I was supporting in the background, though not available through personal reasons to join the call. But Sarah Williams was there as well, wasn't she, as the senior manager? Yeah. Okay, so we are represented on the weekends?
Okay, so we'll go Rachel, Mary.
Can I just make the point that the gold is the highest level of escalation in the system ahead of declaring a critical incident? We're kind of missing the point in that we're normalising gold. It shouldn't be planned to have it every week and in the weekends. When you were, Caroline and I had this conversation, I mean, the gold is the point at which all other actions have failed and you're at the top end of your scorecard, which you've got. And we do normalise it and we mustn't, because the collective success is when you don't get to gold, because all the actions that you've been talking about and your winter plan are effective. So please don't normalise gold, because you've seen what the impact that has on other systems. And I know you're not saying that, but
no, I agree with you completely.
But when you call a gold, you've run out of all options and you're one step away from calling a critical incident.
I absolutely agree with you, Rachel. And I think, sorry, Chair, if I can just say, I think that's why it's really critical that if you're going to send an email with about 20 minutes notice of a gold, a phone call to escalate it, because I'm not sat there watching my emails.
We'll come back to all of this in a second. Mary.
Thank you, Rachel. You've pretty well made the point I wanted to make in a slightly different way. So if I absolutely endorse that point and then say, I think we are misusing our chief executives if we're expecting them to have 2 or 3 calls on a weekend unexpectedly. We've got proper on-call systems in all our organisations. Why are we not empowering the people who are actually on call that weekend to do this? And is there something differently we could do about our bronze and silver so that we're not getting normalising gold?
So yes, there is, because the gold meetings at the weekend are tactical, with people saying, oh, I don't know my numbers. So if bronze and silver were working, then gold would work a lot better. So I think it's a good point that's well made. None of us would choose to be in that position. So our managers need to be discharging their responsibilities for their level of autonomy within the organisations. And the asks and offers can be made between clinicians in services. They don't need to be made between chief execs.
So if I just very briefly come back, Kate, of course, you're absolutely right. And if we're normalising gold, we are allowing the other people not to do it. And I will never forget being a chief exec and standing up because somebody else had stolen my speech. And I managed on my feet to give a speech in the moment. And I sat down, and a very experienced chief exec said to me, don't ever do that again, because all your people now know that you can and they're going to let you. And I just think we have to learn from that.
Okay. Kelvin?
Yeah, I was going to pick up in terms of the actions that are intended to keep us away from having gold calls. Really welcome this document and actually the new Opal framework that's coming out. But I think it will need that next level of detail for us to be really clear on those actions, because I'm noting the action card here. For instance, I'm not sure what a reverse boarding protocol is. I really need to know that when I'm on call.
So, colleagues, and I'm going to come back to Steve's original question to me. Where did this come from and why? The reason why I was initially trying to sort of put this in there is just by listening to that, it doesn't sound perfect. It didn't feel right to criticise what we're doing now because we haven't had the debate. And it felt right that says with it changing, let's get this right because it's that important. Now, if what you do is as a group, you feel you need to pull something quicker together before January, then that's what's come out of this last debate. And maybe it has, and maybe we should have this for December. What do you?
So I don't think this is a new debate, and I think it's the grist to the ESIST feedback when they've been in our system, and also to our NHSE feedback when they sit on our calls. So I'm happy to take something away and to be very clear around expectations of what we would expect people to be doing within the system, within their scope of accountability, rather than things drifting to gold. I agree.
Well, it feels like that was a helpful debate. It feels like it's a December in-year issue because it sounds like it's not quite where it should be. And therefore, Molly, if you could ensure that we agendarise this as an update there. But what was meant to be a 5-minute hello there, we'll get through, has teased out quite an important issue. So thank you for that. So on that basis, I'm not going to take those recommendations as they are. I'm going to ask you to take it away, come back, and if you can put something in place before our next board meeting, fantastic, and then give us an update on December. Everybody happy with that? Good. Okay, so we're moving into some of the strategic items now. So, Rachel, we've got the paper on Director of Public Health Annual Report, so you don't need to present it. At a personal level, I saw it yesterday at the Cornwall Leadership Board as well, and it was well received there. What would you like to seek from colleagues here?
So, I mean, clarity at the beginning, how long we've got for the item, John, just because I know you're short of agenda and I wouldn't want to go over time.
I think the best thing to do is, you see, we've talked around this. We've got a lot of other stuff to talk about. What would you like to get out of the meeting? And feel free to use the time that you need to. But I'm trying to reach out to you to think about what you get from here, as opposed to too much presentation of it, because we've read it.
Thank you. So clearly you've got a copy of the report, which is in the papers. I hope that you've had a time to look at it. The intention of the report is to give a really clear framework and outline of what are health inequalities. It's something we talk about a lot. We have a commitment within the ICB objectives to address health inequalities. So I felt, it's a really important subject that I chose as the topic of the Director of Public Health report, so that I could bring it to stakeholders, including the ICB, to give that framework, that real clarity of the things that are pertinent to Cornwall and the Isles of Scilly that drive our health inequalities. So it's quite a detailed account, which is why I recommend you engage with it in order for us to have ongoing conversations about what inequalities are and inequity, and the difference in outcomes that are increasing across our population. So whilst we use certain things like life expectancy to sort of measure a general sort of health outcome for our whole population, that increased over the previous decades quite consistently, about a year in every 4 years. It's we've all benefited from that. But since about 2011, we've had a stalling, excuse me, and an increase in the gap in life expectancy, which I think we're all quite clear about. So this report is trying to examine what drives those sorts of outcomes, very different lengths of life and quality of life for people, and also which particular characteristics of people and populations in Cornwall are affected the most. So the diagram that I think is on page 8 of the actual report, but is a framework which says on the left, what are the key building blocks? And that includes things like our housing we talked about today, damp housing, looking at employment and our work opportunities, the income people live on. So those things are really key. And you might think the ICB haven't got too much influence over that, but we have the approach using our anchor institutions and growing work looking at determinants of health that are important for that. And then on the right hand side of that sort of diagram, which is essentially the framework of the whole report, looks at systematically through different groups that have been affected. We've talked about income and deprivation and the impact that has. We've also talked about different characteristics, people with LGBTQ+, different black and minority ethnic groups, people with a disability. So these groups are explained in some detail in the report as to why they experience different health outcomes, and I sort of commend the board to engage in the understanding of the differences in outcomes and what drives those. And there's also in the report some specific recommendations of action against those particular characteristics and groups, which can help to guide the work through the system into the future. So clearly, in respect to then what my recommendations for the Integrated Care Board are, I've mapped together with Chris Reed the recommendations from this report for action, which are 14 recommendations in the report against things that the ICB specifically could contribute towards. So that is what I'm asking today, John, people to engage with, is both the content, and please, we'll have a web-based content as well for people to use over time, because I think this is quite a legacy document, because I've chosen this topic and we've spent some considerable time outlining it so that it is there for all system partners to be able to engage with. But then specifically in the Integrated Care Board's sort of sphere, the recommendations, all but recommendations 8, 9 and 11, we felt were directly relevant. And there's some specific details in Appendix 2, which lists a table against those. So in summary, the recommendation for today's board is for the board to review and note the content, and then secondly, to support the recommendations for the ICB in Appendix 2. So I hope you've had a chance to look at that, and happy to sort of take any questions.
Are those the ones highlighted on page 5 and 6 of the summary report?
They're in Appendix 2 of the
Yeah,
whole paper. It's not all, yeah, so I've said it's of the 14 recommendations, there are 11 that are directly relevant and have a specific ask of the integrated.
If I look at the paper that's come with your report, it says on page 4, 5, or the bottom of 4, 5 and 6, it's got what I think are the 14 recommendations. Well,
yes, they're all the 14 general for the report. Yes, that's right.
Yeah. Carolyn.
Yeah, thank you, Chair. Thanks for this, Rachel. So point 2 in the recommendations is obviously about reviewing the health and wellbeing strategy. I was notified a couple of days ago that there's going to be guidance coming out very shortly about the integrated care strategy refresh. So I do think there's something to be done collectively together there, and also once again question, do we need 1 or 2? And I know that's outside of this conversation, but we need to understand what the ICS refresh guidance is going to ask us to do, and then work that alongside obviously the health and wellbeing strategy refresh.
When you say 1 or 2, what's the 2?
Well, we've got a health and wellbeing strategy, and we've got an integrated care strategy, and
them coming together.
They do work in a very they do have similar alignment, because obviously we've made sure of that. But I know that we've had a conversation previously about whether we might have one or the other. But
so
that's
Tom was next, and then Margaret.
Thank you, and thank you, Rachel, because this is a really thoughtful and thought-provoking report, and it's the most detailed explanation of health inequalities that we've seen so far at the ICB. It is a legacy issue, but it will shape our future. Winter will cause pressure, gold will happen, but for some people and in some places, trajectories are predictable and are inequitable. And we have to decide as a system how far we're going to go in terms of our acceptability of unequal outcomes. Lonely and isolated people who don't trust statutory services or don't feel their needs are met are more likely to end up in crisis, and that's going to give them inequitable outcomes, and it's also going to put strain on our system. So we really need to adopt these recommendations, and we then need to work collaboratively to see how we are actually going to address this, what good will look like in 2 years, in 5 years, in 10 years, and at what point inequity is acceptable or not acceptable, and we need to have those very real discussions around this table.
Thank you. Margaret?
Yes, I'd like to ask Rachel a question about coming from a mental health perspective. One of the things that strikes me, because I see lots of things that I don't really want to see in my job, and one of the factors that run through almost every case is poor parenting. And nothing in this recommendations addresses how do we help people become good parents or good enough parents. And could we just think about that for some of the prevention work that we're doing? Is how can we support good enough parenting? And that's why I don't want to call it good, because that's value judgment. But we do need to have basic parenting skills that I don't think are always open to people. And how can we support that? Could you consider that for, if not this year, next year, in our approach? We talk about maternal health, but this goes beyond physical health. This is about mental health.
So clearly any framework's going to miss something out in a specific sort of way, but I'll just respond around the early years work that goes on around parenting support. So there are a whole range of parenting programs that are in place, but I think one of the things that I would be highlighting through this report is the crisis and stress that poverty, poor housing, and a lack of income put on a family in order to do their best in parenting. So I think it's looking at it from that angle of the real building blocks of health, which I think is what I'm trying to get along through this report. But absolutely clearly there's evidence-based things that we can do, and that's the other sort of part of the report. It's not saying, oh, this is the problem. It's saying there are solutions. There's experience over, certainly through the previous decade, when there was a reduction in health inequalities. We know some of the things that we need to do, and that does include early years supports, which is one of the recommendations, to give real focus on the best start in life for those that
So
are
it's more than just
poorest
physical
families.
health. It's all of the mental health.
Okay, thank you very much. Steve?
Welcome the report. I think it was particularly helpful, Rachel, to have the appendix that you talked to, where I think you're proposing specific actions for the ICB to consider as the ICB's contribution to the overarching report. I think most of those actions would directly map to one of the ICB committees, and then the ICB committees could consider that action and how that would move forward. So I think that was really helpful. The only one I felt I didn't have a good understanding of, or the principle's absolutely clear, is the living wage aspects, where I think you're suggesting that is taken forward across all NHS organisations for all NHS staff, and I don't think that's a cause for concern for the reasons that Kate's outlined. But then talks about contractors and contracted services, and I'm not sure I've got enough information to be able to say that's something that could be progressed, or at what sort of timescale. So it wouldn't be a case of disagreeing with that, but I think that would need some consideration.
So, Steve, one of the things I said yesterday, because this came up at the Cornwall Leadership Board, I made the point that the living wage and in some ways, some elements of that are a nationally given thing. It really needs to come back through you as an executive group as to whether this is possible or not. And it didn't feel appropriate either yesterday or, for that matter, today. Have we got enough information to be able to completely sign up to that? I think the direction of travel is possible, but
So I've in terms of band 2 starting salary, it's 11.45 an hour, and the living wage is 10.90 an hour. So
12. It's going to be 12 now.
yeah, but this was before. So 12 as of when?
Now.
All right, okay. So we're at the starting salary for a band 2 is just below the £12 an hour, and for a band 3, but they're nationally agreed pay scales.
that was my point
So
yesterday.
and we haven't got that within our gift to be able to change the nationally agreed pay scales. And it would have been great for some impact assessment if we'd have had a discussion about it before we talk about it in a public meeting. It looks like the NHS isn't signing up to it. So it's that's the difficult thing for us.
Rachel?
I just wanted to clarify, because I did contact the Living Wage Foundation, and they do have a number of NHS trusts and NHS organisations that have signed up to accreditation. There's obviously a discussion. This is a recommendation that I brought as an independent report for the ICB to consider, and clearly we've discussed routes to look at this as a recommendation. But it's certainly possible. The procurement and supply side of this is something that can be phased in over 3 years, if it were to be something that the ICB and other NHS organisations want to do, and it is something the council is committed to as part of their supply arrangements, and that's been a phased approach. So it is certainly possible, just for clarification, but clearly the impact and the decision making process needs to be considered.
We will take the impact assessment away and do it across all of our services. We need to find out how we get assurance that the living wage is passed on to people we contract with, because my understanding is that it's not always that clear through contracted services around whether our intentions are then taken forward in people's pay packets.
So, okay. Emma?
Take it into workforce, John, and have
Yeah,
a look
yeah,
at
that's a good call. Emma?
The council have been really clear that they're very happy to support that, because they've done that root and branch work, and they've got some useful learning, I think, from how you do that impact assessment and how you take it all the way through your third party contracting.
I feel a strange irony, though, that we wouldn't do it ourselves and we'd insist our suppliers do it. So there is some implications beyond the obvious that we would just need to think through on this. So all I'm trying to say here is this is a nationally driven initiative. Let the executive group from the NHS take that to one side. I think it does raise a point. I've written to Oscar and Ali and others, and to suggest that we need a process before it gets to here for us to unpack some of these things. Yeah.
And just briefly, one more point, that this has just moved very recently in the last few weeks, and it has been a quite significant jump from the previous level. So that it is going to have implications across not just NHS, but across all employers.
We'll wait for guidance from NHS National, is my advice. Yeah. Right. Mary, sorry, I can't see that
Sorry,
far.
can we just be clear that we're talking about the national living wage or the foundation living wage? Because they are different.
The real living wage.
Which is it?
And which one are you calling the real
It's
living
the
wage?
foundation one.
Yeah.
It's the real living wage.
But I think from the conversation Kate just had, I think she was not 100% clear. Maybe
So
I'm
if
wrong.
there are two, we need to be really clear what we're talking
Yes.
about. And it would also be great if we are going to do an impact assessment, we know what we are impacting assessing against.
Okay. So, colleagues, Martin.
Sorry, John, just very briefly, I just really welcome the report, Rachel. Enjoyed reading it, and I think it's good for it to come here because it brings back into focus, prevention, reducing health inequalities, which, when we've talked 90% today about what's happening today and, how we turn around performance, I suppose at what point do we come back to, what are our plans or what's our progress, or how do we summarise where we've got to with those parts of our objectives that we don't give as much time to in routine meetings. Barry.
Thanks, John. For speed, just to echo what you said, thank you very much for the report. I really thought it was fantastic. And I want gently, if I can, just to hold us all to account a little bit, because on your point about, for instance, the lack of dentistry, we had a really good conversation here a few months ago about how we might use personalised budgets to impact on dentistry as actually something which, and we only heard in the headlines this morning, didn't we? If we don't have people going to the dentist, they get other cancers and other things that aren't picked up. We had a bit of a discussion about doing something about dentistry, and I just wonder whether, if execs are taking something away, John, as you've suggested, perhaps it'd be really nice to hear back about where that is as well.
So we can do an update on dentistry, but not necessarily personal health budgets. And we'll have to work with Rachel's team because our dentistry is part of a hub rather than, it's not your team anymore, is it? Jonathan Higman's team.
No, still works.
Yeah. In terms of how we take this forward. But yes, we can do that.
Mary, this came up again at the Cornwall Leadership Board. So we've got our meeting with the MPs coming up soon. I have asked the executive group to ensure that for our January board meeting, we have an update on dentistry, because it's been a while since we had that. And it's something which there has been some great work through Chris and colleagues and the team to do that.
Does it include what we talked about around personalised budgets, though? Because that was a real sort of concept of a way forward as to how
why don't we actually make that a discrete item, personalised budgets? Because we had the away day where it came up with some real energy and
targeted.
Yeah. So if we take targeted. So if we could ask, if it's all right with you, Mary, if we ask Kate and the team to take away for a future agenda item personalised budgets on a strategy day, and we do that. So I think what I'm hearing, Rachel, can we just register? Did you want to make any point about point 2?
I want to make a point about the whole report. It's not the first time I've seen it. It's brilliant. Really, really is brilliant. And in terms of guiding us to the places we need to go to, then as our statutory officer for the county, you're definitely doing that, so thank you. There is something about how we work together from a local authority and NHS perspective I'd like to pick up from this, because although there are specific recommendations for the ICB, I think most of them are ICP recommendations where we should be working together, and it comes back round on that loop of, are we all in the same place having the same discussions around the things that will really matter? So I'd quite like to revert some of this to the ICP for us to work out how we bring that alive as part of our strategy for Cornwall. And I suppose that leads me into how many strategies do we need for one county that tells us what we need to be doing in order to make a difference. And I'm not sure there's anything that we're going to produce that will be any better than our Director of Public Health's annual report. And then in Martin, that then builds into it. Did we do what we said we were going to do, and can you measure it? So I'd like to quite take that offline if that's possible, to have a discussion about it.
And Rachel, please take this in the spirit which you and I have had this discussion, but how do we go through a genuine reappraisal as to whether we have, which is Carolyn's observation, whether we have a health and wellbeing board strategy and an integrated care strategy, given the fact we're such a small system? Is this now the moment to actually bring them together? How do we go through that process?
I mean, I know that there's some work going on with Carolyn, Rachel Rotherow and myself working with KPMG to look at governance. We're also looking at reviewing the joint outcomes framework. There may be the opportunity to raise this as some advice.
Carolyn?
Just going to say, so it's actually about the outcomes framework that KPMG are working with us on, and then the route to governance is a byproduct of it. But it's work that we're doing together, and that we can have a look at how we bring this together.
How do we go? How do we make sure we don't go so far down the line of a new health and wellbeing board strategy that we end up with another one and we've missed the opportunity of integrating them?
That's the conversations.
So that's that conversation.
Yeah, that's the conversations
Lovely.
that
Okay.
Rachel and I are having about various things.
So, colleague,
The review will bring them together.
okay,
That's
lovely.
the intention.
Very good, thank you.
Yeah.
So there's recommendations within recommendations here. So there are 14. I think we've made a point about number 2, which is health and wellbeing strategy, and point 6, which is the living wage, which we ought to note as our concerns on that. But for the other 12, are there any other observations that you want to make on those before we say we wholeheartedly support them in our direction of travel?
I'm just whispering to Rachel.
Yeah.
I just wonder whether we can pick up let's get my language right, the Living Wage Foundation. The living wage.
The real
living wage. I'm going to ask Rachel if she can pick that up by the region, because it doesn't really make any sense for us to respond to it without the regional view that everybody should
Good
do.
call. Yeah, no, because it's a wider impact. Okay, so are you happy with the 12 then? Thank you. I'd like to endorse Kate's observations. This is a great report, Rachel. I said this yesterday. A lot of work. It covers all the right topics. I think, thank you for that. It's been well thought through and well presented. And therefore, if it's okay with you, I'd like to move to the main recommendation, which is we've reviewed and discussed the report. I think very positively. We've made the 2 noted directions of travel, and we've effectively given the support for the 14, but the 2, we've actually sort of said, can we just park those for a moment until we have a greater insight on their impact? Is that okay with you? Lovely. And do pass on thanks to your team, because it's a big effort to have got here. So thank you so much for that.
Just say one other thing.
Yes.
I'm just thinking, in terms of the more we pay people up to a certain point, we know it's got a gross benefit in terms of their life, their family's health status and opportunities. There is something around inequalities monies and how that might fund the living wage. So Simon and I'll take that away to look at the money that's coming in next year and how we could use that regionally, Rachel, as a way of perhaps making it easier.
Okay, thank you very much. Now, Rachel, before Rachel, I come to you on the Prevention Concordat for better mental health. Did you want to say something at this juncture?
So I do. The Mental Health Concordat is a great piece of work that's been done between council colleagues and ICB colleagues. What it hasn't done is engage with our CFT colleagues around bringing it together explicitly. So I think people might have been involved at practitioner levels, but not necessarily at an organisational level. So I want to apologise at the start of that it hasn't been through CFT's internal governance. That said, it's a great piece of work, and we will take it back round through our mental health board that we're going to set up.
So I was going to ask you, Debbie, your view as to whether we can endorse this, or should we actually say we need it to go through your governance process first?
I'm going to put one hat on and then another hat on.
Very good.
So as the partner member for mental health, I absolutely welcome it.
Yeah.
And I think it follows really well from the Director of Public Health's annual report as well. So I can absolutely understand the alignment of the 2. However, I would just say that given that the previous Concordat ran from 2018 to 2023, the bit that's missing are the outcome measures that support some of the statements about good progress having been made. And so I do think that for the next iteration, it would be really helpful to actually have some outcome measures that we could track as a board. If you look at the programme spend for mental health, learning disabilities and autism for the ICB in its totality, that benchmarks well there or thereabouts. So I think it would be a good mechanism for this board in due course to say, are we seeing the outcomes commensurate with the level of spend? And finally, it would be really helpful with my CFT hat on. to be able to support and endorse this overtly. There are a few areas in here, like reference to Outlook Southwest and IAPT, which is already outdated terminology. So we'd be really happy to work with some finessing of that. But I wasn't clear from the documentation. Is it the Chief Executive of the Council that signs this off? Is it the Chief Executive of the Integrated Care Board? And what the mechanisms would be other than through the Health and Wellbeing Board for monitoring? Thank you.
You on it?
I'd look to Rachel.
Rachel, would you have a view on that?
Yeah, so I think I wasn't aware about the need for further engagement, so apologies if that wasn't done. I know that the system group does include CFT, but I understand the governance issue. So Health and Wellbeing Board was previously where it had been approved, and OHID, the Office for Health Improvement and Disparities, asked that ICBs endorse this. So that was the route in which we were guided to take it. I mean, essentially, as you say, thank you for your endorsement of it as an approach, because it's one of the areas that we have a high rate of suicide. Almost 66 people a year on average die by suicide in Cornwall. It's one of the reasons that we acted early to have this joined up approach to try and prevent that escalation of mental health needs upstream, and looking at that approach and looking at all ages, trying to bring it all together in one place. So the officers, I think, that have been involved have worked very well with the system to do that. So I hope that you would, support that and feed in any further comments through your board, through CFD's board on as the lead for that. But today I hope that in order to sort of lead the way to go forward as one of the leading areas in the southwest to have a prevention concordat for mental health, that we would support this today in order to show that commitment.
Yes, I'm not intending to hold this up in any way, and I think we could just add to it that we would agree some impact measures across. As you rightly point out and remind us, Rachel, we do have a higher than average or higher than we would expect suicide rate in our system, and therefore all the more reason for us to be asking ourselves the question as to what impact are we having. I think there's also what impact is being held or experienced in primary care. I think that they too at practice level might well want to think about how effective is the prevention work, because if we think about conversations we've had about our urgent and emergency care and shifting the dial there, providing community alternatives to statutory services is in part, of course, designed to improve outcomes for people, but also in part designed to reduce pressure on scarce specialist services.
Just on the outcome measures, I mean, it is an area that I'm quite sort of pleased to say that there's a structured approach to measuring impact. So those commissioned services under the Concordat that include things like People in Mind, we've discussed here before, and other interventions, working with the job centre around debt and mental health, etc. So those preventative ones, they do use the short Warwick-Edinburgh mental wellbeing scale to measure specifically the impact on mental wellbeing. So I think it's one area which I feel quite assured there is very good person level impact data which we can use to measure those outcomes.
Okay, so I'm just trying to think about how because we have talked about this before, and I was hoping that this was going to be a full support at every level. I think we have got full support. Is it? Yes?
I'm not supporting.
No, I say we have got full support. It's just that would it be fair to say that we at this position can note, endorse and adopt it as the ICB, noting the fact that it's still got to go through the CFT governance process, but CFT are supportive of it. Is that, Margaret, would you be happy with Debbie with that as a note?
Yeah, and I think we can develop the impact measures subsequently.
Is that okay, Tan?
Yep.
Did you want to add something?
I do just want to add
Okay.
a couple of sentences, okay? So I think I'm absolutely supportive of the Concordat, but I don't think I can go past without saying the feedback from the consultation that we did with the community is, and this is not a judgment on existing services, it's about resources. There are not enough resources going into mental health in our county in terms of the need, and we as a board needs to look at that and the allocation of resources. Effectively, what we are allowing to happen is that if you compared it to some physical health attributes, people would be having broken legs and not being treated, because we have got an exponential rise or deterioration, if you like, in the general population's mental health. And this has been going on and on and on. We have to look at this as an equality issue and as a service issue, please.
Okay. Thank you. So we're going to endorse and adopt, noting it's still got to go through the CFT process, but with CFT support in the room.
Can we have another action?
Yeah, another action. Yes.
So I, Sam Allen, who's the chief exec for Northumberland and Newcastle ICB, I've got it wrong, but she's way up north. They've developed a prioritisation tool for mental health, learning disability and autism that they are using as part of their annual resource allocation cycles. So I've already asked her for it. I'll go back and ask for it again, because as we move out of the long-term plan for mental health and the mental health investment standard ceases to be the parameters through which we are measured, I think we need to have something locally that we can hold ourselves to account for, not just the Mental Health Concordat, but for the DPH's annual report, because written in there is also around people being able to look after themselves and mental health.
Mary, final word, because we're now over half an hour late, but Mary.
I'm just asking for some advice from Molly, because I'm just not I'm trying to get my head around the governance point of accepting and so on, but it's still got to go through CFT. So does the wording have to be slightly different? Because otherwise we're taking the decision for the CFT board without, I mean, and Margaret might be perfectly happy, but I think in governance terms, Molly, would it be better if we put something that said pending a discussion at CFT?
Seek your advice.
Well, Molly would give us some advice.
Yeah, well, I'm looking to how far you'll go, because if you're happy for us to push this, or
Well,
you.
we are named in it.
Yeah.
So and there are lots and lots and lots of actions in it.
Okay.
But my big request is that we see the impact
Molly, what's your
measures
advice?
that we're going to measure. But I don't want to hold this up.
No, Molly, what's your advice? Can you speak into this?
My advice to you would be that your board considers a report and analyses the implications and then reports back to the ICB, and then the ICB can complete the loop in accepting all the recommendations. So we can accept them pending that task being completed.
Works for me,
Does it?
Molly.
Yeah, thank you. Rachel?
Would you like to bring it back for
It sounds like it,
ratification here? Just to clarify, there aren't any financial implications for the
No, but it is
existing resources.
it does need to go through the right processes. So thank you, Mary. It's
Endorse Kate's point about we do need some sort of prioritisation tool. And
Okay.
We need to understand where the money should go. It's not necessarily, you'll be surprised to say.
okay, colleagues. Thank you, and thank you, Mary, for helping us get to the right answer on that part there. So, Rachel, again, thank you. Vital piece of work being done there. I think you've got general consensus. We just got to go through some of the process there. So let's move on, please, colleagues, to item 15. Cornwall and Isles of Scilly self-assessment following Lucy Letby case.
Thank you, Chair. I will keep it brief because I'd like to point out the paper that we did, the self-assessment we did, was at a point in time very shortly after the verdict that Lucy Letby received after the trial. We had a letter from NHS England outlining areas, 5 objectives that we needed to look through, and hence we did our self-assessment. However, there are 3 key components of safety and governance systems that will be examined as part of the inquiry following the very tragic case involving Lucy Letby. The only things that I really would like to point out, Chair, are the really important link between patient safety and understanding what's happening within organisations and freedom to speak up, whistleblowing, and some of the more subtle ways in which we listen to what's been said, either by staff, by families, by patients. And the paper was written. It was a great opportunity to sit down with partners across the system to write the paper and understand what's going on within providers. We have very well established freedom to speak up processes both within CFT and RCHT. I think there's some work that we need to do within the wider system, and I suspect there will be more information coming out and more actions following the independent inquiry. I'm more than happy to take any questions, but I just want to reiterate the paper is a point in time, and there's more work that needs to be done. And we know that we've got Martha's Law as well, which is another very sad case where, again, listening to patients and listening to families is such an important part for us to keep people safe, and the whole culture around that, civility. We know civility, we've done lots of work of incivility and how it costs lives. We just need to, it's helpful to go back around, whether as boards or other groups, and review all of those processes that we put in place to ensure that people are heard.
Okay. Anything you want to add?
John asked me what PSERF stood for and I couldn't tell him, and then I found it. I know what it is, but I didn't know what the letter stood
Actually,
for.
it's a really important point. So the patient safety and information, and all of us, is the way in which we monitor patient incidences across our system is so important, and it's changed because I think that the feeling was previously, and certainly what we were being told, was that we focus much more on the process of investigating an incident rather than what the issues were and how we learnt from it. So the whole idea of moving to a much more wider investigation and trends of incidents is so important. And when you look at PSERF, it wasn't around during the time that Lucy Letby was a nurse. And what our previous framework for investigating serious incidents, it was very clear on categories. So a lot of the babies that suffered and subsequently sadly died, their deaths were often put down to medication errors. If it had been categorised as an unexplained and unexpected death, it would have set off a whole different process with coroner's inquests, medical exam. So the PSERF, whilst we have some concerns about it being quite broad, I think there are some real safety nets and benefits. And we were one of the first areas, RCHT, to go live with PSERF was a pilot. So something that Kim and the teams across our systems are talking about.
Few questions from me. Rachel, do we know when the regulation around all of this might be decided? No, we don't. No idea. No indication.
The independent inquiry is ongoing at the moment.
Okay.
Or will be.
Just talk to me for a second about freedom to speak up and what that means for all of us.
Was Margaret going to say something?
I just wanted
regulation
on the point about freedom to speak up.
Okay. Yeah.
Right. We need to look at other mechanisms as well as freedom. Not everybody wants to use the freedom to speak up process. So it's about trying to make sure that we have cultural acceptance in the trust to encourage people to raise their concerns. Almost freedom to speak up has become almost too structured to be really encouraging of people to raise their concerns. So that's something we're working on at CFT.
So, yesterday at the Chief Exec's meeting, there was a session around maternity and looking at the Ockenden reports, but also feeding in some of the outputs from Lucy Letby. And one of the things that came out very strongly, as if there are three things that you should be looking at as a non-executive around your services. One's your outcomes. Two is what are your staff saying? Informally as well as formally, so walking around, just hearing what the chat is around the hospital. And the third is what the mothers and families are saying around accessing care in your services, because the latter two help reinform what you're seeing in terms of your numbers. So I think there is something for us around hearing things, because we know that a lot of our vignettes are around people who don't feel heard. So whether it's staff or whether it's people using our services, there is something around, if our ears are open, are we responding to what we're hearing? And we perhaps aren't at the moment.
That's exactly the point we're trying to make. It's about hearing.
So actually, Margaret, part of the reason why I was trying to phrase it on regulation and then freedom to speak up is that I've only been involved personally in one discussion wide outside of Cornwall on potential regulation, but that too felt that the current freedom to speak up wasn't actually going to be fit for purpose to go for this.
For what it's designed for.
For now, yeah,
But it's
but-
not designed to get it. You know, we need to make sure that we have many mechanisms
Yeah.
to hear the voice in
Quite
this
right.
case, just
Yeah.
described.
And I guess my question is that piece of work in train?
So freedom to speak up wasn't around during Lucy Letby. That was one of the
Yep.
so freedom to speak up is another way of raising concerns to people who are not necessarily executives, who are not senior managers. We have freedom to speak up guardians who are trained that anybody can go to, and then they can work out a way of resolving the issue or escalating the issue. The rigour around and the process around whistleblowing often put people off. And I think it's fair to say, in my experience in the NHS, the minute you put metrics to something, like we have freedom to speak up, it changes the way in which we behave, which is why my point about culture is so important. RCHT did a huge amount of work whilst I was there around civility. So we know, and we know that with Never events, going back to Never events, if you have a culture where people can't speak up, in theatre, it used to be when I was a nurse in theatre, it was a very threatening place. So having the ability to speak up and not to be shouted at or humiliated or made to feel small or made to feel that your concerns are dramatic is incredibly important. But freedom to speak up won't capture all of that. Neither will whistleblowing. But some of the subtleties around how we listen and how we behave, and that's the job for us as leaders, as role models in our behaviour, in being civil and being just decent people, is so important with this.
So let's move to the recommendations, colleagues. Are we happy to note and receive the PSIRF assurance report?
Yes.
Yep. Note and approve the proposals for assurance and oversight monitoring at QPOC, Neil, as a standing item with effect from the December 2023. You happy with that?
It's been
Yep.
through QPOC.
Yeah. Note and approve the proposal for quarterly monitoring of the PSIRF gap analysis and action plan at board with effect from January. Everybody happy with that? Susan, are you happy with that set of
Thank you very
recommendations? Lovely. Thank you very much, everyone. We're nearly there.
I didn't know whether you two wanted to say something. No, okay, sorry.
To be respectful of time.
Okay.
Thank you. As a chair to a chair, you understand the pain that's going
Imagine what your heart must be
on.
feeling.
Okay, so let's move on to item 16, which is the ICB committee terms of reference. Carolyn.
So I can be really quick about this, Chair. This is simply here for feedback and for information for the board. It's the survey results that we did of the board membership a few months ago, and this is just to be open and transparent about the responses that we received from it. We will be using it to triangulate our findings and using it as part of our governance self-assessment that we have to do and send to NHS England at the end of the year. And really, Chair, this is to bring to the board's attention the
Terms of reference.
Oh, apologies. There we go.
Yep.
Then you go.
Yeah.
You've got it in front
Molly,
of
well,
Chair.
delighted with the board survey, by the
Yeah,
way.
that's
but
good. We
come
won't have to do that in part two.
Yeah, we'll
There
do
you
that in
go.
part two.
We're
In terms of
done.
terms of reference, go for it. Terms of reference.
Okay, so I'll be really quick, just noting the time. So there are 7 appendices attached to this paper for approval, and these appendices are revised draft terms of reference. These terms of reference include changes in risk oversight, as we've discussed in the earlier paper. They also include, thanks to the chair, a really helpful suggestion on scrutiny checklists, which will be included in our work cycle of business. So it's really important to demonstrate that the board is implementing improvement through the scrutiny and assurance of its committee. And just under section 3, there's also a summary of what the findings were in the committee effectiveness review around risk and the areas that we needed to focus on. That's also been included in the work that those committees will be doing. And in the next step session, you can see as well that from December onwards, the committees will receive revised cycles of business, which include all those areas of work, including the scrutiny checklist and, of course, the in-year and strategic risk assurance monitoring. So with that, I just wanted to highlight that there's also a set of terms of reference for the audit committee, which is not for approval, but for information, because the audit committee meets on the 9th of December. And so at this point, it's just really there to show the consistency in how the terms of reference have been constructed. And I'll just pause and ask for the board's approval. For those
Lovely,
terms of
thank you.
reference.
So on the basis, this has been a massive piece of work, actually, in terms of reviewing, looking back, how did we do, what did we do well, what didn't we do? we've got a whole new set of terms of reference with new members, updated terms of purpose, and of course a revised committee from the Citizens Engagement Committee to becoming the Personal Experience Equity and Prevention Committee. So I did want to tease that out so that we spend more of our time focusing on prevention and on equity than maybe that our committees have done before with these checklists. And if everybody's happy with this, can I just take everyone that's happy with these terms of reference for all these committees? Yeah. Then effectively, if I could ask through your good office, Molly, if you could just make sure that all the committees that have currently got the old attendees and membership, if they could all be stood down from today and from tomorrow, effectively, all the new members and all the new attendees and the new agendas flow. And from that, each committee will be asked to have its own checklist. It'll be asked to actually have its own forward plan. They'll all be asked to actually reflect their risks based on our corporate risks. And then each of the chairs will be asked to come back at each of the board meetings in the flow of in-year and strategic. We'll come back to here and each of the ICB chairs will be asked to give assurance and the degree of assurance they've actually got from what they found in terms of the detailed plans they've actually got in place. So if everyone's happy with that, yes? Thank you, everyone. That's been a massive piece of work. I know that too. So, colleagues, it's now 1:05. Ali would like to say something.
I just wanted to raise something on the forward plan, Chair, if I can.
Yes, forward plan.
Because I thought you might have just gone straight to lunch then, which I'm really keen to do as well.
Good Lord, of course, yes.
I've been asked to
Turn the
ask
page.
if there's any chance that we can bring the Cornwall plan to the December ICB and whether Mark Barton can be invited to present it.
So, I think really the plan was for it to come to the next strategic one, which is January.
Oh, okay. I think there's some delays and some urgency around this. Apologies, Chair.
Okay. What would you like to do in terms of the Cornwall plan?
Have individual boards seen the Cornwall plan? Mary and Margaret?
I don't think so.
It's quite important. I mean, it's a good document at Cornwall level, but as it starts to have an impact on what the health part of that does, we do need to be completely aligned on what the health and social care bits of that do.
And that we're ready for it.
Yeah.
So could it go through to be helpful? Could it go through NHS boards in December and come to a January ICB board, because then people have had chance to look at it.
Okay, it has to go through a public board. No, because our next public board is January, but it's early January.
Okay.
But it may be all right not to, we could go through it in December and then refer it onto our public board.
We do
in
have
January.
a public board in December, so that's.
I just think it's important.
I mean, I can feed back. It's obviously not something I'm leading on, but I'm happy to feed that back.
Yep.
Does that mean that we wouldn't be able to bring it here until January if it can't go to the other boards?
We're sticking to the structure of in-year and strategic. So it's only through that discipline we can actually make sure we spend enough time on in-year, because next month is going to be rammed-packed full of in-year discussions with winter.
But
And
it would
that.
be helpful, John. We could give some feedback after a discussion in early December.
Okay, so I'll ask Matt Barton to share it.
Yep.
And just so I'm clear, you wanted to go to the CFT board, the RCHT board, and then come to the ICB
Correct,
board.
yeah. And I don't see any reason why, as it's the second Thursday in the month, if yours is earlier than ours, then probably by the time we get to the second Thursday in the month of January, we can probably cover it off. Thank you for raising that. Yes, and I should have turned the plan. Is there anything else on the forward plan that anyone would like to raise? Neil, you've raised your observation about green and that type of issue. So if I could ask the executive group to take this away through SEG and to really plot this out. Now, this is our first one today. If you can really plot this out, it'll help get everyone thinking about what the future papers are. Okay, moving on. Any questions from the public relating to the agenda? Please raise your hand if you want to ask. I'll just wait a sec. No? Okay, thank you. In which case, at coming up for 10 past 1, we're going to close the meeting. And we're running half an hour late. So shall I suggest that we start at 22? Is that all right with everyone? If we start sharp Can I ask for one thing though before colleagues on the call go? Carolyn, did we actually send out a revised link? Because I can see some of the our public come in on there.
I'm going to have to check that because I didn't send out the links.
So
but-
colleagues on the call who are coming back for part 2, will you please watch your emails? There'll need to be a new invite sent out with a new link for part 2.
I am just putting a message into the part 2 because somebody's already started it just to say we're running half an hour late and to come
Lovely.
back.
Right,
Okay.
thank you very much. Okay, everyone, see you at 22. Thank you.
Thank you.